Hello and welcome. As usual, I'm Corey Campbell, and welcome Bob Marley. Always happy to see you. I'm not 100% sure that I'm a really true Sigma scientist, but I do my best. And yeah, I hope everyone has had a great week and is having a great weekend. Been, I think, at least a week, maybe a little bit more since I last streamed. I tried to do a workout stream earlier today. I got a new camera, first of all. That should hopefully make the quality of the workout streams, well, the video quality at least, better. I tried to get it, before I went to try to do the workout stream. Like, I was obviously setting up and I tested things out, and everything was working smoothly before at home when I tested it out. But then, go to the gym studio, try to go live, for whatever reason that I couldn't figure out or didn't want to, didn't have the patience, I guess, to figure out. It didn't work, but I think I know now what the problem is. And so for my next workout stream on Wednesday, scheduled for Wednesday, I should have it up and running with the new camera. Oh, well, thank you. That was the least I can do. Just try out the new camera. And since that was sort of maybe my way of coping, since since I failed at getting the stream started, I figured, well, I might as well like try and, go a little bit heavier. Maybe test out my limits or, test out some old limits. Old personal records. Just music a bit. There. Since I suffered an L for the workout stream, at least getting it started, I was like, well, I gotta find a W somehow. And so I went heavier. Oh, and Paul, welcome. Thank you so much for passing by. Always happy to see you. Yes, it is a Saturday stream. And in fact, maybe moving forward for the next little bit, my streams will be mostly limited to the weekends. Just because my schedule's sort of transitioning a little bit, where, as I mentioned before, looks like I'm gonna pretty much officially start full-time at the biotech startup, as a scientist. And so, like, during the week, my time might be limited. I should still be able to stream during the week, time to time. But I think a lot of my streaming time will come on the weekends with, like, workout streams, science streams. Yeah, I'm trying to, like, get things in order. In addition to the new camera, I realized that probably the mic on the new camera isn't the best either. So I probably need to invest in better audio equipment, or like an actual microphone. Even though I think still on the new camera, it's an upgrade from streaming from my phone and the phone microphone. But still, I think I should probably also like bite the bullet, so to speak, and invest in, a wireless mic that also ups the audio quality, so that I can hopefully have good,
welcome to
decent
Flavor Country.
Oh. That. But thank you for the follow anyways. I appreciate the sentiment. So I should still be able to be on Prime panels, no problem. If in fact he continues to invite me, which I hope he does. I never want to take it for granted, getting invited to Prime Kai's Reverie or any panel. Like, I'm always grateful, no matter how many times I'm on, because like Prime can invite whoever he wants, pretty much, and I'm a nobody. I'll do my best to never take it for granted. But like, yeah, if I continue getting invited to Prime panels, I will happily go on. So yeah, what was I saying? Right, yeah. So next workout stream should be Wednesday. Should be better video quality. I was really actually like excited, like as I was walking to the gym studio. I was like, oh yeah, like I'm really great to like have this better video quality. And then again, I couldn't get it up and running. I probably could have tried for, the 2.5 hours that I was there to get it up and running. Oh, and Globus. Welcome. Shout out to Globus. How are you doing? I hope you're doing well. See if I can do this properly. Oh, and Cernu, welcome. Hope you're doing well also. But definitely everyone should go give Globus the Elder a follow. They do great content. And they've been kind enough to invite me on their stream as well, and have a great chat. So yeah, so as I was trying to get set up for the workout stream earlier this afternoon, I spent a good, 15, 20 minutes like troubleshooting it. But since I had the time booked, okay, and I paid for the time, I didn't want to spend my entire time troubleshooting, getting the stream up and running. Like, okay, after 15, 20 minutes, I gave up, I quit, and I just started working out on my own. And I did have a good workout. As I shown in the Discord, I got a nice lift in, closely matching my personal record. And actually, like, I'm like almost 100% sure I could have gone heavier, but basically my grip was my weakest and I don't use wrist wraps or anything like that on principle, for me personally. So yeah, on today's stream, as in the title, so there's a lot of content, as usual, that I want to cover. Probably not going to be able to get through it all, but there will be the main topic. I'm going to cover quite a bit of the research about medical assistance in dying in Canada. And one of the reasons why I want to cover it is, well, out of interest, since, this is a fairly recent development in Canada. And also, some of the legislation is changing, or the rules about MAiD is changing in 2023, which I will go over as well. And this is like evolving or emerging research, right? Like medical assistance in dying in Canada has only been legal since I think it was 2016, 2015. And obviously, so there's not a lot of research about it. We have some, but this is something that, we should continually track how the trends evolve. And there are definitely some concerning trends, or potentially concerning trends, that I will go over. Even though I support medical assistance in dying, it's not all. There are definitely valid things to be concerned about that were brought up. So another reason why I want to cover it is because last Friday, so 8 days ago, I was on Wick's panel specifically about this topic. A shout out to Wick. For Death of Certainty. I think I was obviously supporting MAiD, since that's my position. And there was obviously an opposing viewpoint. And I think the opposing viewpoint was, I would say, not the best grounded, but that's my opinion. I'm biased, obviously, since I'm on the opposite side. But basically, a lot of the arguments that were put forth were not real arguments. Yes, so I'm gonna cover some. But basically, to sum it up, at least this is my interpretation of the arguments, right? I don't want to mischaracterize what the opposing viewpoints on the panel were. But this is just how I interpreted their arguments, and I could be mistaken. Basically, the main message was that this should be a last resort. That they're concerned, or at least there was concern expressed about people just kind of like going up to the doctor and getting like a quote unquote like prescription for medical assistance dying, or like it would be pushed upon them or encouraged. And so it's like if you look at the rules and regulations and the legislation, like it's built in, sort of trying to address that concern. And Bako, welcome. How are you doing? I hope you're doing well. And no, we're definitely not, at least I'm not trying to. And also shout out to Bako, because they're technically a fellow streamer. And apparently they stream Halo Infinite. Definitely give them a follow. Yeah. And I know, at least, Eucharist, also a fellow streamer. Shout out to Eucharist. He definitely has an opposing viewpoint that is almost certainly more well-grounded, more well-reasoned, and more nuanced. I think it is, based off of what I experienced on the panel, mostly a more issue. And I'm hoping sometime soon I can at the very least have a one-on-one conversation with Eucharist. I know they're pretty staunchly opposed, but also they're just great to have a conversation with. It's like I met Eucharist in person, and I know the space they're coming from, and I know it's from apparently a good space, and they allow for nuance, and they allow for civil discussion. But maybe I can expand it into a viewer panel on the topic of panels, since I was happy with the last viewer panel, the last and so far only viewer panel that I had. That was a success. I'm hoping in the next couple weeks I can have another viewer panel. We just need to come up with a topic. And also, shout out to you, Oily Olive. Thank you so much for passing by. And yeah, if you're lurking while working, totally fine by me. I mean, so it's funny. Me, Eucharist, and I, like, there's definitely actually a decent amount of overlap, even though they identify themselves as a conservative. But there's definitely, as we found out in person, there's actually quite a bit of overlap between a decent amount of our views. You want to, well, I should clarify, you want to expand it to more than 4, Bob Marley? Because I would say 4 is probably, like, my limit, personally, on what I would want to hold as a panel. I think, personally, at least for me, in my opinion, more than 4, it gets, so last one, it was 3 for the first, like, hour and a half. And then, remember, Montreal Player came in, I think, for the last hour, or the last 45 minutes. But yeah, I think 4 is a sweet spot. And technically, you know, I'm both a participant and a moderator, so, you know, I'm biased. I'm probably not, you know, I'm definitely not holding panels in the most unbiased way. And the topics today are, we're going to briefly cover basically some viral infections, as was posted by Bob Marley in the Discord. There's Strep A infection going around, apparently, in the UK. There's a bunch of viral infections circulating in Canada. I can say with certainty, because it's in the headlines almost daily. And it seems like also in the US, they are struggling with the same. I think we're just going to dive right into it. I don't want to delay getting into the research of medical assistants dying. And yeah, I think 4 is the maximum. Like, as much as I participate in panels, in large panels, for me personally, at least the way I would want to have, like, a conversation that is, you know, productive by my definition, I think I would need to hold it to limit it to 4. No, I'm pretty sure it was like the last hour, like last 45 minutes. Okay, so to the topics. I'm probably not going to be able to cover everything that I want to cover today. Anything that I don't cover today, or some that I don't cover today, I will cover. I plan to stream again tomorrow evening. Just to maybe, I don't think I'm going to be get to cover this, but maybe just as a, you know, a teaser for tomorrow's stream. There's, for those who are also here for the workout streams, you know, there's some research showing that, oh, you can get some great benefits of exercise in just, you know, 8 minutes a day. This almost sounds like, you know, those, whatever, popularized, you know, workout programs. Like, oh, you know, 10-minute abs. And then there's also, like, this came across my headline, my newsfeed, where it's like, yeah, a long COVID paper under investigation. And then there's more and more research coming out showing that vaccines are effective against long COVID. But I'm probably gonna have to cover these ones tomorrow. And for now, I'm gonna cover briefly some of the viral infections that are going around. So respiratory syncytial virus is at the very least circulating in the United States and Canada. I can't speak for the UK. Well, so I think that's where, like, the rubber meets the road, right? This is how it works in social media or in the streaming space, especially as a chatter. Where it's like, you know, when you have oh wow, thank you so much for the sub, Oily Olive. You're always so generous, and I'm always super grateful. Yeah, I can't thank you enough. But like, I think we know now that the ability to remain anonymous, like, just allows people to, kind of behave in a ridiculous way. It's easy to have a hot take, or an insane take, if you're able to remain anonymous, and you can't put a face, to the take, or a name and a face to the take. And I see it even in, when I'm on Prime's panel, I will very often have Fabian Liberties at up, or their stream up as well, because like Scott is absolutely a regular on Prime's panel, and so like I peek into what Fabian Liberties chatters are saying about me, and they're not so nice. At least generally speaking, they're yeah, I'm not gonna repeat anything, but let's just say they very much dislike me. But I would say it's also easy to trash talk behind a screen. But I don't take it personally. It's like, whatever, I can handle it. They can say whatever they want. That doesn't bother me, but I just find it so interesting, where like I'm confident that, if I go and like confront them, or if they want to say it, face to face, or actually show their face, it becomes a different story. And yeah, no, Paul, like, I know that you're not, like, so I have the utmost respect for people. Well, I respect everybody, but, I have a greater respect for people that are, willing to stand by their positions and, pretty much, like, put a face and a name to their position, or at the very least, as they say it with their chest. And, sorry, link here. Thank you so much for providing that, Cernu. I will likely bring that up. I'm going to bring it up now and save it for the topic. Yeah. All I'm going to say is the viewers of Fabian Liberty are definitely a unique bunch, and they stand out to me. Oh, and Boy Meets Mini, welcome. Sorry I didn't see you. Shout out to Boy Meets Mini. I hope you're doing well. Definitely everyone should give Boy Meets Mini a follow. I believe they should probably be streaming. I don't want to misinform, but they typically stream on Sundays, pretty regularly. They might be streaming tomorrow, at the very least. Everyone should give Boy Meets Mini a follow, because they do great racing stream, and they cover CRT. If only now, I think if anything, like, from what I understand, NASCAR drivers are like on the complete opposite end of the spectrum. I just view them, like, I don't know anything about NASCAR. I find real life watching racing super boring. So yeah, we're gonna cover this. Oh, and also on the topic of Boy Meets Mini, I have Boy Meets Mini provided this great article about RSV in the Discord. Encourage everyone want to join the Discord. There's some great resources there. So we're gonna start with this, and what is respiratory syncytial virus? This is just a good primer. So respiratory syncytial virus, more commonly known as RSV, sends thousands of children to the hospital every year in the US. During September and October 2022, health professionals across the country have watched an unprecedented spike in the number of cases. This usually mild but occasionally dangerous respiratory infection in children. Jennifer Garado is a pharmacist who studies pediatric infectious diseases. She explains how RSV infects the human body, who is most at risk, and what it might be causing, and what might be causing this year's outbreak to be worse than normal. And this totally appears to be occurring also in Canada, as I'm going to cover. As far as I know, like, everything that's happening in Canada is also happening in the United States. We're just pretty crazy flu season, respiratory syncytial virus, and a couple of other circulating things. RSV is a common RNA respiratory virus that affects about 2 million children under 5 years old annually, nationwide. Researchers think that most children have been infected by age 2. Like the flu in most areas of the US, respiratory syncytial virus usually circulates from November through March, and then mostly disappears during the summer months. with only sporadic cases being seen. So this seems like it pretty much parallels the flu season. Who is most at risk? For most people, especially those who have had an RSV infection in the past, the virus only causes mild symptoms, cough, runny nose, and fever, with instances of wheezing and decreased appetite more common in young children. So essentially, it sounds like pretty similar to a common cold, if you've had a prior infection. No, it's not CRT back in the day used to stand for cathode ray tube for like TVs and monitors. Now, in whatever the popular culture, CRT means critical race theory. But young infants, especially those under 6 months old, born prematurely, or with congenital heart, lung, or other health issues, are at increased risk for more severe symptoms. The US CDC estimates that 1% to 2% of infants younger than 6 months who get infected with RSV require hospitalization. In an average year, around 250 children die from the disease. Any amount of people dying, especially children dying, is tragic. It's hard to kind of put this in context, where it's 1 to 2% of infants younger than 6 months old who get infected require hospitalization. I'm just trying to get it, and I'm trying to get an impression of the fatality rate of is this 250 out of 10,000 children affected, or is this 250 out of 500 children affected? But they say 1 to 2% of infants younger than 6 months. So I imagine this is tens of thousands, hundreds of thousands. In recent years, researchers have found that RSV can also cause severe disease in high-risk adults and people older than 65, which makes sense. Generally speaking, high-risk groups for those who are immunocompromised, it's very young children and the elderly. And obviously those who, are immunocompromised due to medication or chronic illness, etc. The main reason RSV sends babies and young children to the hospital is because the virus infects and kills surface cells within small sacs of the lungs. The body responds by increasing the production of mucus and fluid in these areas, but the extra mucus can plug up and obstruct these parts of the lung and make it so that an infant doesn't get enough oxygen. The second common cause for hospitalization due to RSV is pneumonia. This is essentially a bacterial infection in the lungs, where a person's lungs fill up with fluid. The pneumonia can either be triggered by the virus itself or by a secondary bacterial infection. Finally, some infants get so sick that they struggle to eat and are unable to take in sufficient nutrients, eventually landing them in the hospital. And thank you for that, Paul. Much appreciated. I'm definitely I'm bad. Trigger and content warnings. I'll be transparent with that. So, how concerning is this year's outbreak? On average, RSV... Okay, so now we're getting a sense. My impression was tens of thousands of children affected each. I was just trying to put this number in context of the 250. So it's 250 out of tens of thousands. So 60,000 young children to the hospital each year in the US. In 2022, however, the virus has hit early and hard. According to the CDC, doctors have found more cases the week of October than any week in the prior 2 years. And this also mirrors basically the trend that we're seeing in Canada about the influenza virus, where it's the infection rate so far and the fatality rate that we've seen so far in Canada in the flu season. It's breaking records. As in the beginning of this current flu season looks like the peak of previous years. Where it's we're on a ramp up. Health officials aren't yet sure why the outbreak is so bad this year, but the COVID-19 pandemic may have something to do with it. Some research has shown that seasonality of RSV has shifted. In 2021, RSV infections started much earlier than normal, and over the summer of 2022, they never quite went away. One theory as to why RSV season is starting earlier and hitting harder is that due to social distancing measures since 2020, an unusually high number of infants and children are experiencing their first exposures and infections at once. Right. So, I don't know if there's any evidence of this, but I would say this is speculation, although I'm not a medical professional. But like, you know, since young children born either, close or during the pandemic, they are understandably not exposed to your typical pathogens as a result of, the restrictions. And so their immune system might be a little bit more immature than what one would expect pre-pandemic. Maybe. How can you protect against catching RSV? Like colds and the flu, RSV infections spread when people touch dirty surfaces or from respiratory droplets. When an infected person coughs or sneezes, health professionals recommend that premature infants and infants with certain medical conditions take a monthly monoclonal antibody medication called alavizumab during the RSV season to help keep them out of the hospital. There are a few RSV vaccines under development, but none are yet approved. For now, preventative measures are the best way to avoid an infection. If someone is sick with symptoms that look like a cold, it may be best to avoid close contact until they feel better, especially if you have young children or high-risk people around. Pretty good primer on RSV. Basically, the precautions that you would take for COVID. Like, it's virtually the same, if not identical precautions that you would take for RSV. Limit contact with, bodily fluids. Wear a mask if you can, or, wear it whenever you want. Is there any particular reason you know of why these infections may be especially lethal in the UK? An excellent question. Let's see. Maybe some of these articles answer. Off the top of my head. And I guess I should clarify. Because what we're seeing, at least, again, my country, Canada, greater lethality amongst the very young. And so I'd ask you, when you say especially lethal, are you also seeing a disproportionate amount of young children unfortunately passing away? Or are you just seeing greater overall lethality? Yeah, I don't like them either, especially as a gym goer. I don't like working out with a mask. I don't like running on a treadmill with a mask, but I have done it. Totally during the height one of the heights of the pandemic. I was totally going to the gym with a mask and running on a treadmill. Yeah, strep A. So it's Streptococcus, that's a bacteria. That's a little bit different. And I have the article that you sent, which we'll go over that. So, yeah. RSV and flu. U.S. children's hospitals stretched by respiratory viruses. So, some people are saying what's in the ether is Canada's healthcare system is totally in a very critical situation. Definitely overburdened, understaffed. And that was true before the pandemic. And the pandemic is only making that worse. And especially this flu season or this respiratory virus season. Our healthcare system is in shambles. So there's definitely people making the argument or putting forth the notion that, since this is public healthcare, this is the argument, or this is an argument in favor of going private, where you wouldn't have a struggling healthcare system if you were more like the US. But the US is seeing very similar, if not the exact same things. So, yeah, RSV and flu, US children's hospitals stretched by respiratory viruses. So, hospitals in the US are taking emergency measures to respond to a spike in respiratory viruses among young children. Some are building overflow tents to house more beds, while others have canceled planned surgeries. And this was published, about 2 weeks ago, almost exactly 2 weeks, 9 days ago. Sorry. The US is facing a surge in viruses such as the potentially dangerous respiratory syncytial virus, RSV, the one that we just spoke about. Children under 5, especially newborn babies, are most at risk of developing severe symptoms from RSV. And young children under 6 months are being taken to hospital with RSV at 7 times the rate seen several years ago, according to government data released earlier this month. Other viruses such as flu, rhinovirus, and coronavirus are also adding to the spike in hospital admissions. The US Department of Health has said more than 3/4 of children's hospital beds were full in November, although experts say this is likely an underestimate. Hospitals are bursting at the seam. Same thing in Canada. Daniel Rauch, the chief of pediatric hospital medicine at Tufts Medicine, Massachusetts, told the BBC. It's more than we've seen in certainly the last couple of years, he said. The total volume is more than I've seen in my career, almost 3 decades worth. The Children's Hospital Association, which represents more than 220 hospitals across the country, said several were at over 100% capacity. In California, some hospitals are using tents outside of emergency room buildings to make room for additional patients. In Oregon, one children's hospital has had to take emergency steps to allow more space for children in its intensive care unit. Boston's Children's Hospital in Massachusetts said last month that it would delay elective surgeries due to the surge in respiratory viruses. One second. Aren't these increases in viral and bacterial infections? So, I don't know if they're related. I can't remember how strep A is spread. I do not believe it's in the same manner as, like, respiratory viruses. And I don't think strep A is considered a respiratory infection. And so, like, this... But I'm going to look that up later, because I could be wrong. My information about strep A is, like, really deep in my brain. Even though I'm more comfortable with bacteria since I work with bacteria. I have a decent microbiology background. But, like, yeah, I haven't covered strep A in a while. But I don't think they're related. But it's possible. This might just be a confluence of factors, or like a perfect storm coming together, where just like are susceptible infections. But I don't know what that would be. It's because the public health care has been defunded by people who want to ultimately privatize it. Yes, would agree with that, especially that is occurring in Canada. Oh, well, yeah. So definitely this article is covering that. I know you pay attention to COVID still, compared to me. Is anti-COVID people simmer down since there's less focus on COVID stuff in media? No, there's at least based off of what I'm seeing on social media, and even just the media in general, there are totally still, vaccine hesitant. There are still totally people. If anything, there is more people now more than ever that are not necessarily anti-COVID, but just kind of like no longer think about it. It's like literally like in the past for them, when it is still very much a thing. It still exists. It's still killing people, and it's still something that we should pay attention to. Yeah, I need to clarify that. I can't remember how strep A transmitted. So, experts believe cases of RSV and flu have surged this year because protective measures like mask wearing and social distancing during the coronavirus pandemic protected some children from exposure, leaving them more vulnerable to infection this year as people relax those behaviors. Children's hospitals are still recovering from a reduction in beds due to the coronavirus pandemic, when they made space for adults who are more at risk of severe COVID infections. The Children's Hospital Association and the American Academy of Pediatrics have asked President Joe Biden to declare a national emergency to help remove some hurdles to expanding pediatric hospital capacity. RSV is a respiratory illness that typically results in cold-like symptoms for adults, can be dangerous for young children and those with underlying health conditions, as well as older adults. In severe cases, it can cause bronchiolitis, Uh, that should be inflammation of the bronchioles, which includes a buildup of inflammation in the lungs and trouble breathing. The US does not have a vaccine for RSV available to all children, although scientists are trying to develop one. Oh yeah, so yeah, I don't necessarily want to blame anyone for, putting COVID in the back of their mind, because, like, yes, they're, depending on, the situation, I totally understand and take the point that different people have different priorities, absolutely. And, like, if just making your next paycheck or paying rent is your top priority, like, I don't blame anybody in that situation. If, COVID it isn't, like, the front of their mind. And yeah, thank you so much for the lurk. Always appreciated. And I hope that I'm hoping you've gotten over your bacterial tooth infection. I can speak with some decent experience about bacterial infections, because I was trying to get over one for a long time. So, speaking about the US, okay, and seems like, at least in some parts of the United States, the healthcare system is overburdened as a result of these respiratory infections. And the same thing is holding true in Canada, where intense flu season for Canadian kids needs solutions now and longer term, doctors say. Hospitals struggle to keep up with surge in cases. Flu infections are raging among children and hospitalizing them across Canada, say pediatricians who are calling for urgent and longer-term solutions. Last weekend, hospitals across the country were forced to scale back regular service to deal with a surge in influenza illnesses. CHEO in Ottawa said the Red Cross will be deployed to help out with its surge of cases. And like, yeah, so it's a mix of, like, not enough beds and not enough staff. But it seems like, the bottleneck is staffing, where, there has always been, pre-pandemic, a shortage of doctors and nurses. The pandemic has made it worse, and now there's, like, this extreme shortage of basically all healthcare professionals. A respite care facility in Calgary closed to redeploy staff to a children's hospital. BC Children's Hospital declared an emergency for 30 minutes on Saturday to quickly boost capacity and resources. Newfoundland and Labrador's Children's Hospital canceled some scheduled surgeries and appointments. Like, this pretty much spans all across Canada. In BC, that's out west. Newfoundland and Labrador, that's, well, where I am, the east. Doctors say the moves reflect a surge in influenza on top of long-standing pressures on both pediatric hospitals and care providers in the community. Cases of respiratory syncytial virus have, in the meantime, stabilized after spiking earlier this season. For the week ending December 3rd, a total of 6 influenza-associated deaths were reported among adults, according to the Public Health Agency of Canada's Blue Watch report. In the same week, participating provinces and territories reported 212 influenza-associated hospitalizations, 31 ICU admissions of children 6 and under. That's up from an average of 11 influenza hospitalizations, maximum of 35, at pediatric hospitals from 2014-15, 2019-2020. Said Dr. Jesse Pappenberg, a pediatric infectious specialist at Montreal Children's Hospital. I was a patient at this hospital for quite a long time, well until I was no longer a child. This shows that we have had an early and intense influenza season so far this year, hitting the pediatric population particularly hard, said an email. Across Canada, influenza activity continues to remain higher than expected for this time of year. Watch report said. The number of weekly influenza-associated hospitalizations well above levels typical of this time of year, and it's above levels typically at the peak of the influenza season, the report's authors noted in the pediatric section. Yeah. Definitely in my circle, everybody has something, or like is either recovering from something, or they're newly infected, something to that effect. Similarly, in the US, Rochelle Walensky, director of the Centers for Disease Control and Prevention, said Monday that flu is at its highest level that country has seen for a decade. So far this season, 21 children and youth in the US have died. Canada this season, 5 influenza-associated pediatric deaths have been reported federally as of December 3rd. Annually, the number of the deaths for that age group were in the single digits before the COVID-19 pandemic. Bend the curve with flu shots, and so it does seem like at least one of the variables at play: low vaccine uptake, low flu vaccine uptake. Influenza is overwhelmingly causing a lot of problems, particularly for children under 5, said Dr. Fatima Kakar, a pediatric infectious disease specialist at St. Justine's Hospital in Montreal. But it's not necessarily the flu alone that's the problem, she says. Rather, kids catch the flu, which leaves them prone to really significant bacterial infections, like pneumonia. That's when they land in hospital. Kakar says she'd like to see an emphasis on influenza vaccination for children, including publicity campaigns. I say this because I think it's not too late, and especially in parts of the country where influenza hasn't told, I would really like to see encouraging and making it easier for parents and their children to be vaccinated. Whitehorse-based pediatrician Dr. Catherine Smart called it immensely concerning that children who are acutely ill and need attention quickly are having trouble receiving it. But there are other bigger picture problems throughout the pediatric healthcare system that deserve attention. Smart, past president of the Canadian Medical Association, cites wait times for surgery for young people with scoliosis, a curvature of the spine, as an example. I've had patients that had to put off their post-secondary school planning because they don't know when they're going to get the operation and the recovery, Smart said. They say, well, how do I go off to college if I don't know that I'm going to now have to have a massive spine surgery and be out of commission for weeks or months? Said. Some of these teens have been waiting 3 to 4 years for this operation. So effective vaccine, other healthcare needs for children are provided outside of the hospital, which is especially important in the first years of life, such as autism services. Some kids aren't able to access services to improve their speech, social skills, and cognition. Once a child is in kindergarten, they may no longer be eligible for certain help because the developmental window to intervene has closed. These are problems that we're seeing across the country, Smart said, suggests bolstering nurse staffing and retention. So, obviously, I understand it's good. Just like Canada, the US is a large country and it varies by region. But I often hear, and I'm sure it's true in some regions in the United States, but I often hear, like, wait times in the United States are so much better in Canada. And based off of what I've seen in the data, like the raw data, that does seem to be true overall on average. I'm just curious, regions of high wait times in the United States. How does that compare to wait times in Canada? She also wants to see more uptake of the flu vaccine among children and adults, bend the curve for overwhelmed healthcare system. The good news, Appenberg says, is that the influenza A H3N2 strain that is mainly circulating in Canada now is genetically the same as the strain in this year's influenza vaccine. That bodes well for good vaccine effectiveness, although that needs to be assessed in field studies now underway. In the long term, researchers are evaluating newer vaccine technologies for better, longer-lasting flu immunization, he said. Like Smart, Appenberg suggested governments invest in our child healthcare system's capacity so that we can better handle these types of unpredictable surges of infections in our pediatric population. When you look at Canada, we rank 30th out of 38 countries for childhood well-being. So that's pretty close to the bottom, actually. Smart said, it's really shocking to think a country as wealthy as ours is doing that poorly for our kids. But it's because we do not have a strategy for children. Health officials also recommend that people mask in indoor public spaces, screen daily for respiratory symptoms, stay at home when sick, practice hand hygiene, and keep surfaces clean to reduce the spread of respiratory illnesses such as RSV and flu. Pretty much same precautions as COVID. Oh, and Zero, welcome. Thanks so much for passing by. I've been putting off back surgery for over 20 years. I don't want the bill, so I deal with chronic pain every day. Which I'm super sorry to hear that. And my heart goes out to you. Because even though I have limited experience with back pain, especially like I've never had chronic back pain. I've had, bouts here and there of acute back pain. And like, so if you're, and so like I have somewhat of an idea of how debilitating and disabling it can be. And if you're dealing with that on a daily or chronic basis, then like, yeah, like my heart goes out to you. And like, I wish you had access to the healthcare that you needed. Well, at this point, the U.S. system is overwhelmed too. So yeah, obviously, the finances are a greater variable in the United States. So these should not be related to measles. Just because, like, generally speaking, even though there's been a reduction in the vaccination rate against measles, generally speaking, we have pretty good immunity as a result of vaccinations against measles, at least in Canada and in the US, as far as I know. Like the MMR vaccine, there's pretty good uptake of that. That's a possibility, although I don't necessarily want to speculate that far. Technically a possibility. I have insurance, but the deductibles are almost as much as the surgery, which is like, yeah, that is crazy to think. And there are some reports of these similar things happening in Canada. Let me see if I can find. Yeah, so found it. 1 second. So totally. There's some, pretty heartbreaking stories all about heart surgery. And this is published, not that long ago, a week and a half ago, where it's like, as alluded to in this article, even in the one about the United States, like surgeries are being put on hold, or life-altering surgeries are also being canceled or put on hold, and it's happening all over Canada. So, and it seems like I don't know how RSV and influenza is faring in the UK, but this was sent by Bob Marley in the Discord, which Bob Marley is always providing great articles and great research. We're going to cover this as well. So, but it seems like the UK is also dealing with, at the very least, Strep A. Yeah, exactly. Believe me. I don't want to go on a rant about capitalism because I think I do that enough. But totally, it's funny. Like, can those who are, pro-capitalist, are we allowed to attribute these types of things to capitalism? Where it's like, it seems like capitalism never gets anything negative, put forth against it, or at least, all of the body count associated with, communism and socialism, that always gets, put forth. But to associate any sort of like body count, capitalism, you can never do that. Oh, gonna check that out. Okay, so yeah, and because so data shows 13 under 15s in England, 1 in Northern Ireland, and 1 in Wales have died since September. So Strep A, Streptococcus, bacterial infection. So yeah. is yeah, this is bacterial, so not viral. So totally, not totally, but different, pathogen than a virus. And yeah, it's a gram-positive bacteria. And it's, called Streptococcus just because it's kind of like, well, it's based mostly off of how it looks like under a microscope here. So, what's happening with Strep A in the United Kingdom? Data from the UK Health Security Agency shows 13 children under 15 have died of Strep A in England in September. 2 other such child deaths have been recorded in Northern Ireland and Wales, taking the UK total to 50. Group A strep bacteria can cause many different infections, ranging from minor illnesses to deadly diseases. Illnesses include the skin infection, pedigo, scarlet fever, strep throat. While the vast majority of infections are relatively mild, sometimes the bacteria cause a life-threatening illness called invasive Group A streptococcal disease. That's we're sad to hear that. And this was like, I'm assuming, so in the past, 48 hours, sounds like more children have died, or at the very least, more people have died. UK HSA has said there is no evidence that a new strain is circulating, and that the rise in cases is most likely due to high amounts of circulating bacteria and increased social mixing. Pharmacists continue to use social media to complain about shortages of antibiotics, including the liquid version of penicillin, which is often given to children. The Health Secretary, Steve Barclay, said on Wednesday that checks within the Department of Health and Social Care had not revealed an issue with the supply of the medicines. However, the National Pharmacy Association has pointed to blips in the supply chain of liquid penicillin. While the Association of Independent Multiple Pharmacies said pharmacists across the country were struggling to source all they needed, can't be all, I guess this is all of the article. I guess pretty short and sad. So how it's transmitted? Although I imagine it's not necessarily like, as the article said, you can get an infection of Strep A through various parts of your body. As I say, strep throat. I believe it can also be like a bacterial infection, lungs, etc., etc. Well, obviously, like, the route of transmission likely be different. But I just want to see if there's any sort of like information about how it's typically transmitted. Yeah, so swab of the affected area for laboratory testing. Yeah, whatever area is infected. Yes. Yeah, but I don't think I don't necessarily think it's like fits in the category of like respiratory infections, but I could be wrong. But either way, like what's occurring in the United States and Canada with these viral infections, where it's like, yeah, we have a disproportionate of children being infected, dying. At the very least, it seems like the UK is also dealing a bacterial infection that appears to be disproportionately affecting children and unfortunately resulting in some passing away. But they don't really give, they give their speculation as to like why this is happening. Just like the rough idea that there's just like greater bacteria circulating and that increased social mixing. Which is like, is that actually true? Obviously, that's not that's difficult to actually objectively measure. Like, is it potentially the result of, like, since, at least we went from pre-pandemic to, pandemic phase and lockdowns, and then, in the vast majority of countries, I think virtually every country except for maybe China, has lifted restrictions. And so, like, has this resulted in just, like, a flood of increased socialization, increased socializing and interaction that is just, like, off the scales, that then these bacteria and viruses are able to be transmitted? I don't know. But I guess it's a reasonable thing to speculate as to why this is happening. But, like, yeah, at the very least, I'm going to be keeping a close eye on what's happening in Canada. And, like, where are these trends coming from? Because it is pretty perplexing. And it doesn't seem like any of the articles really have, I think, a good explanation. And that tweet that you sent, Bob Marley, more measles. The case count in Ohio's outbreak has risen to 56, 20 hospitalizations. Among the new cases are 2 children who were partially vaccinated at 1 dose. Okay. Well, yeah, I know in the United States, they have little pockets of measles outbreaks. But yeah, it's also, like, pretty large. And unfortunately, as the result of, increased anti-vax rhetoric, the vaccination rate for MMR, or measles, mumps, rubella, has dipped quite a bit. And so it seems like, one of the consequences, unfortunately. Even though, like, the MMR vaccine, like, gives great protection, it's well researched, and there is no link to autism. It's bizarre. Okay. Now, moving on to the main topic. It'd be interesting to see the breakdown of bacterial plus viral spread on factors like class size. Yeah, totally. That would be super informative. Unfortunately, I think that would be a very difficult, and not impossible. That's probably, like, a very difficult analysis to carry out. But that would be super interesting, and probably it would be super informative. So now, the main focus of the stream: medical assistance in dying, particularly or specifically in Canada. So yeah, 8 days ago, I was on a panel hosted by Wick and it was, how many other people? I think it was like 6 or 7 people in total, so fairly large panel. And I would say, there were 3, including me, in support of medical assistance in dying. And I think there were 3 opposed, if I remember correctly. But at the very least, there was at least 2 support and 2 opposed. And so, I've made my position clear. I'm very much in favor. Not in favor. That's the wrong word. I'm not, like, pro medical assistance in dying. Like, I support it. I support people having access to this. I support having a system in place that allows for, screening, and where appropriate, people having access to medical assistance in dying. Oh yeah, rheumatoid arthritis. Totally. I cannot fully empathize, but I have a decent understanding of rheumatoid arthritis. Very much, there's a lot of overlap between Crohn's disease and rheumatoid arthritis, and totally, many of the medications that are used in rheumatoid arthritis are used in Crohn's disease, and vice versa. They are almost interchangeable when it comes to many therapies. So totally, I definitely don't have the strongest immune system. So, yeah. The reason why I wanted to cover medical assistance to dying and cover the research specifically on medical assistance made in Canada is because, like, the people, the other panelists who were against MAiD, like, I really don't think they were putting forth strong arguments. Or, like, pretty much, like, arguments that don't apply to what Canada is doing with medical assistance dying. Where you can... so this is a final report of the expert panel on MAiD and mental illness. This is by the Government of Canada. No. That was... I think that was specifically about mental illness and, like, you know, the treatment of mental illness, or, like, you know, therapy and medication for the treatment of mental illness. This was, like, 8 days ago. So not yesterday, Friday, but the Friday before. And so, this is a report, pretty much in the title, final report of an expert panel, about, you know, new measures that are going to be coming into effect starting next year. I believe March 2023. I remember correctly. Where it's like, basically, you can potentially apply, get medical assistance dying, as a result of mental illness, or like mental illness can be full criteria, and it doesn't necessarily have to be mental illness in combination with, you know, cancer, or in combination with, you know, incurable fatal illness. But as part of the eligibility criteria, I can, or at least the eligibility criteria that they recommend, expert panel. Second, yeah. So, legislative safeguards on medical assistance in dying, as amended through Bill C7. So there's potentially, like, as they outline here, 2 tracks that you can apply to in order to get MAiD. There's track 1, track 2. And just the title of track 1, you know, natural death is reasonably foreseeable. Basically, you know, fatal illness, or, you know, high probability of being a fatal illness. You know, almost a foregone conclusion that this individual will pass away. And then there's track 2. Natural death is not reasonably foreseeable. Title. Basically, there's no expectation that this person will pass away from their illness or condition. And part of the criteria that's built in is, like, you know, ensure that another medical practitioner or nurse practitioner has provided a written opinion confirming that the person meets all of the criteria set out in subsection 1. And then there's also ensure that there are at least 90 clear days between the day on which the first assessment under this subsection of whether the person meets the criteria set out in subsection 1 begins, and the day on which medical assistance in dying is provided to them. So, like, basically, you know, a 90-day waiting period, where it's like it's not some sort of, you know, spur of the moment or impulse decision. Ensure that the person has been informed of the means available to relieve their suffering, including, where appropriate, counseling services, mental health and disability support services, community services, and palliative care, has been offered consultations with relevant professionals who provide those services or that care. Where it's like, you know, basically, they want to ensure that the patient is informed, at the very least, of other alternatives to MAiD. As in, like, you know, if they're going to apply to MAiD, it seems like they need to make sure that other alternatives have been presented or, the patient has been informed of them. Where it's like, it seemed like the way they framed those who were on the panel who were opposing MAiD, they framed it as in like, this person just, shows up to their doctor's office, and they just apply to MAiD, apply to get medical assistance dying, and then like it gets administered, right away. And that is clearly not the case. Where it's like it's built into like the criteria, as they sort of say here, track 2, that they need to be informed, be ensured that that MAiD is basically a last resort. That this should not be a first line go-to for just about anybody. And so ensure that they and the medical practitioner or nurse practitioner referred to in paragraph E have discussed with the person the reasonable and available means to relieve the person's suffering, and they and the medical practitioner or nurse practitioner referred to in paragraph E agree with the person that the person has given serious consideration to those means. So that's an excellent question. I do not believe so. Where, because like suicidal ideation or suicidality, like I think that would, no, for sure. I suspect that would be exception. Because like generally speaking, I'm not a mental health professional, or medical professional anyway, but to my understanding, suicidal ideation or suicidality, kind of like a temporary state, or like, once you deal with kind of like, immediate crisis, essentially like offer them treatment, that is potentially effective. You can kind of treat their suicidality or suicidal ideation. And don't think suicidal ideation or suicidality is considered like a mental illness per se, at least in and of itself. I could be wrong about that. But yeah, from my understanding of the reading of this, and of basically of the research that I've seen and that I will show, it's like basically the majority of people who are applying and receiving medical assistance dying, they are receiving palliative care, or basically like end of life care already. And like the average age, like over 70. And so it's like, as far as I can tell, people who are suicidal or are experiencing suicidal ideation are not receiving. And I don't think any medical professional would approve them under that criteria. Where like if they are going to a medical professional expressing suicidal ideation, suicidality, like I think they would be pretty much rejected from it. Yeah, exactly. Where I think this is one of the reasons why they put in those safeguards, where it's like, ensure that the person has been informed of the means available to relieve their suffering. And Revolving Sim, welcome. Thank you so much for passing by, and the kind word. Like, I wish, if a shot of me, or if my blood had the ability to remove suicidal ideation or suicidality, or had any sort of treatment, therapeutic benefit, I would totally be giving my blood away as much as I can. So this is what I'm going to cover now. That's an excellent question. Because, like, what does the data say? And Revolving Simp, I hope you're doing well. as I mentioned earlier in the stream, MAiD in Canada has only been around for like whatever, 5 years, 6 years, whatever. Not that long. And so like, we're still very much in, well, hopefully we'll always be in the data collection process. But we're still kind of like teasing out trends. We're still, in the process of getting good data and, tracking long-term trends. But 1 second. But before I cover the research, let's go over some simple stats. So this is the second annual report on medical assistance in dying in Canada, 2020. And so there are some trends. Oh, well, I'm hoping, hydrate yourself. And a nice healthy meal I think can go a long way. But I hope your hangover is gone by tomorrow. So the number of medically assisted deaths continues to increase in 2020. So compared to 2019, as they sort of say here, in 2020 there were 7,500 cases of MAiD reported in Canada, accounting for 2.5% of all deaths in Canada. So, like, this represents a pretty small sliver of deaths in Canada. The number of cases of MAiD in 2020 represents a growth rate of 34.2% over 2019. Like, basically, it increased by about a third. So it went from, I think, roughly, like, 4,000 to 5,000 cases to 7,500 cases. Like, yeah, that is a sizable increase. When all data sources are considered, the total number of medically assisted deaths reported in Canada since enactment of federal legislation in mid-2016 is 21,589. That's a good question. I don't think they tease it out. Basically, I don't think they analyze the data in that fashion. Because, like, basically, I'm reasonably sure, okay, this is not acting as a substitute or replacement for suicide, because, like, I could be wrong, but pretty much I don't think anybody expressing suicidality or suicide ideation, they would not be able to receive it. At least so far, okay? This is pretty much reserved, as of right now, for those who are pretty much, who have a fatal illness. Where, as I said, like, their death is a foregone conclusion. It's only starting in 2023, March 2023, where, like, potentially a mental illness can be a sole eligibility criteria. So, like, as of right now, you couldn't even apply to this just for the sake of suicide or with the intention of suicide. Like, you have to have some sort of, like, diagnosable fatal illness currently. So the average age at time of MAiD being provided in 2020 was 75.3 years. Like, yeah, the average age, 75. And whatever. I don't know for sure, but I think it's highly unlikely that demographic, has, like, high rates of suicidality. And as they say here, cancer was the most commonly cited underlying medical condition in the majority of MAiD cases during 2020. followed by cardiovascular conditions, chronic respiratory conditions. Okay, even then, that's tricky. Just because, like, I don't know that they would document, well, first of all, how do you tease out, like, is suicidality or suicidal ideation different than, someone applying for medical assistance, in dying? You know, people label this as, like, assisted suicide, but at least, again, my thought process, this is based off of my understanding. But again, I'm not a mental health professional, but, like, suicidal ideation is something specific, and that is a specific kind of, like, frame of mind. And, like, you know, someone with a terminal illness, and they're looking to die, or they're looking to get MAiD, medical assistance dying, would you call this person suicidal? Or just, like, you know, wanting to die with dignity? I would not call a terminally ill person, who is applying to MAiD, not label them as suicidal. I personally, again, my opinion, I personally would just, label that as someone, wanting to die with dignity. And that, again, suicidality, suicidal ideation is, like, distinct, different from. But I know that there's gonna be people that say, like, yeah, if you're terminally ill and you want to die, well, then you're suicidal. Just cut and dry for them. That's different in my mind. Like, again, someone who, you know, who has cancer, and they know that they're almost certainly gonna die in the next, you know, year, and they're applying for MAiD, like, would I call that cancer patient suicidal? I personally wouldn't. Yeah, totally. Like, I'm not opposed to gathering that data. I just think it would be, like, difficult to tease out, potentially. So the majority of MAiD recipients received palliative care and disability support services. During 2020, the majority of MAiD recipients received palliative care. So, like, yeah, palliative care is, you know, basically kind of like care for the terminally ill, or like those who are very severely ill. Oh, this is somewhat synonymous with, like, end-of-life care. And so, like, the vast majority of people who receive MAiD, they are already receiving kind of like end-of-life care. Of the MAiD patients who did not receive palliative care during 2020, 88.5% were reported to have had access to the, had they wished, avail themselves of palliative care. And about half required disability support services. And yeah, the majority of those half received and yes, yeah, those are, like, some basic, I think, demographics that I think are important to keep in mind. And some of the research that I'm going to show pretty much echoes the same things. So, what does some of the research actually say? Oh, jeez. I don't think I've ever... One second. I've ever had any sort of chat like that to YouTube. All right, sorry about that. Okay. So, like I said, there's a little bit of research out there. So, I think one of the important things to point out, at least in my mind. So, another one of the arguments against medical assistance in dying in Canada is, like, you know, some people have expressed concern that, you know, this will, you know, disproportionately affect those of lower socioeconomic status, or like basically, you know, this will it would potentially also result in a disproportionate amount of, you know, people living in poverty receiving medical assistance and dying. Basically, you know, as a method of kind of like, you know, wiping out poor people, as they say. Like, is that a valid concern? Totally. And actually, I'm gonna show a story that, you know, it shows it as a valid concern. But that is just like one story. But if you look at the data, okay, and this is some data about, you know, what are the demographics of the individuals receiving medical assistance in dying in Canada. And I went through some of, you know, the simple demographics. So like average age is like 75. And like, you know, the majority of them are receiving palliative care. But like, what is the socioeconomic status of the individuals who are receiving or applying for medical assistance in dying? This is a case control analysis. So, this is pretty much like attempting to answer that question. So, economic constraints are a common explanation of why patients with low socioeconomic status tend to experience less access to medical care. We tested whether the decreased care extends to medical assistance dying in a healthcare system with no direct economic constraints. So, what were the overall conclusions? So, patients with low socioeconomic status are less likely to receive medical assistance dying under universal healthcare insurance. An awareness of this imbalance may help in understanding patient decisions in less extreme clinical settings. So, like, you know, basically, it seems like, off of this study, that generally speaking, those who are applying and receiving medical assistance in dying, they actually, like, on average, tend to be of a higher socioeconomic status. As that study, I believe the authors are here. Medicine, Department of Medicine, Department of Psychology, Public Policy, Princeton University, Psychology, Princeton University. So it does not seem like any economist is involved. And these are all psychologists or medical professionals. So, what did they do? I know you say unfortunate. I would say that that's a notch in its favor. So yeah, a total of about 50,000 palliative care patients died, of whom 920 received medical assistance in dying. So like about 1,000 out of 50,000 palliative care patients received medical assistance in dying. So like 1 in 50, pretty much is the breakdown, or like a little bit less than 1 in 50. And so the other, whatever, 49,000 did not. Medical assistance in dying was less frequent for patients with low socioeconomic status. Okay, so 166 out of 11,000. As they say, like, if you look at the socioeconomic background, Oh, and thank you so much for the. I need to get a message for the. But thank you so much for lurking. Thank you so much for passing by Boy Meets Mini, and also thank you for sending that article about RSV. And Bob Marley thinks, I would suspect, Bob Marley thinks economists should be involved for every study that's ever done. So when you compare this with, high socioeconomic status, so like for the low socioeconomic status, you get 166 out of about 11,000. And then those with high socioeconomic status, you get 227 out of about, 9,200. This equaled a 39% decreased odds of receiving medical assistance in dying associated with low socioeconomic status. So I don't necessarily disagree with that, actually. In terms of data analysis and analyzing raw data, I would agree with you that economists are pretty good. I would say they fail at data interpretation. And even then, actually, now that I'm saying it out loud, I'm not even sure that I agree with their analysis, at least. I can show some economic studies that the analysis is pretty shoddy. But yeah, I would agree with you that economists are pretty good at data analysis, but data interpretation, I think they're pretty trash. Or they can be pretty trash. Obviously, I'm not going to say all of it. Like, I've shown economics research on stream before, and I've definitely shown economic studies. No, they're awful at interpreting. So the relative decrease was evident across diverse patient groups after adjusting for age, sex, home location, malignancy diagnosis, healthcare utilization, and overall frailty. The findings also replicated in a subgroup analysis that matched patients on responsible physician, a sensitivity analysis based on a different socioeconomic measure of low-income status, and a confirmation study using a randomized survey design. So it's like, yeah. But bear in mind, this was not all of Canada, as far as I can tell. As they say, this was a setting, Ontario, Canada. So it was like one province. And what are some of the reasons why, or potential explanations as to why you're seeing this divide amongst medical assistants dying? Or like, why is it that those who come from a lower socioeconomic status background, why do they have a lower rate of receiving medical assistance dying? One of them might be sort of a bias in the medical system, right? Kind of like stigmatization, or as I highlighted here, it may just be that those who are poor, like their pain and suffering isn't taken as seriously as those who are privileged. Where it's like, if you come from a poor background, like, this is a new term for me. I've never heard of this before this study. Or like a new fallacy, termed the thick-skinned fallacy. It's like, well, you've had a crappy life, so you must be used to your crappy life. So now you're coming to me with your pain and suffering? Oh, you should be used to your pain and suffering. So like, yeah, as they say, people are prone to pitfalls of reasoning. Poor patients, for example, may feel less able to advocate for themselves or more reluctant to express their dissatisfaction. In addition, clinicians may underestimate the distress experienced by poor patients due to faulty intuitions about a life of hardships, termed the thick-skinned fallacy. We hypothesize such behavioral pitfalls may have important implications for medical care, thereby leading to unequal patterns of care for poor and for rich patients experiencing a similar serious situation. Here we explore how this hypothesis might extend to an extreme condition requiring understanding and communication, namely medical assistance dying for a palliative care patient. So it's like, yeah, as they outlined and I already said, like there might be some, systemic bias against poor people and, not taking their pain and suffering as seriously as you should. Uh, I think there is kind of like, when it comes to the psychology and I don't know, mindset, I think there's probably a decent amount of overlap between bankers and economists. At least that's my speculation. Okay. So, right. So you have this graph here, medical assistance in dying, absolute frequency. So it's, overall low frequency, which is great. And you can see sort of the trend as you go from, low socioeconomic status to higher. And they've broken it up into quintiles. So yeah, frequency of medical assistance in dying plot shows frequency of receiving medical assistance in dying among patients receiving palliative care who have different socioeconomic status. Like, yeah, 5 data points or whatever, 5 quintiles. And you see, it's just like an upward trend. Basically, the richer you are, it seems like the more likely you are to receive medical assistance in dying if you're in palliative care. So what's the overall discussion? We studied thousands of deaths in Canada and found that medical assistance in dying was significantly less frequent for palliative care patients who had low rather than high socioeconomic status. The imbalance extended through the range of socioeconomic status and was equally strong during initial and later years of the study. The imbalance is not easily attributed to access to care, ability to pay, medical diagnoses, intensity of medications, choice of physician, responsiveness to treatment, public preferences, thoughtless impulsivity, or reciprocal compensation. So it's like, as I alluded to earlier, like it's the system does not appear to allow, which is good, does not appear to allow for, it's kind of like an impulsive decision. It's like, oh, if you want to, want to basically get assistance, medical assistance dying, like you're not gonna get it like 24 hours or 48 hours. Like there's a process built into it where you don't. There's no same day service when it comes to medical assistance dying in Canada. That's basically the overall message. Our research supports earlier patterns observed in other countries around medical assistance dying. In particular, patients in the USA undergoing legalized assisted dying are more likely to be highly educated and financially secure compared with the population average. Patients in the Netherlands receiving assisted dying are prone to have comparative social, economic, and educational privileges. Patients in Switzerland who undergo assisted dying tend to live in affluent neighborhoods. Patients in Belgium who receive assisted dying tend to have higher education. To our knowledge, these tangential findings, apparent in past studies, have not been rigorously analyzed, have typically been ascribed to economic constraints. Well, funnily enough, I actually never got into future. What I would say is as much as I support medical assisted dying, not in favor of suicide booths. Our data suggests the unequal distribution of medical assistance in dying may occur beyond aspects of care related to cost. And so yeah, as pretty much summarized here, Canada isn't the only country with medical assistance in dying. There are a few other countries that have it as well, although there's different regulations, different system. But this is the best comparison we can make. Canada's legislation and regulations are unique, so you can never do a perfect one-to-one comparison, but you can draw some parallels with other countries. And I think a reasonable enough comparison. Where it's like, yeah, we have data from the Netherlands, we have data from Switzerland, we have data from Belgium, and as they outline here, seems like the experience in Canada pretty much mirrors the experience in the other countries. Where it's like, yeah, as we are observing here in this study, those who are rich and who are highly educated tend to receive medical assistance dying at a greater rate than those who are not rich. So poor patients, one factor could be faulty doctor-patient communication. Poor patients often feel disempowered to advocate for themselves, right? So it could be that those who are poor just may not feel like they're in a position to ask for this type of care, right? I have no doubt that it's probably not the easiest thing to ask for. And, maybe as a result of stigma, and maybe as a result of, as they say, be feeling disempowered, they may not be in the best position to advocate for themselves. Where if they're really in pain and suffering, and there is sort of like a need for medical assistance dying, they just may not be able to speak up for themselves. They have lower trust in a healthcare system, and they have less rapport with clinicians who elicit their preferences. Religion, ethnicity, or other confounders could also contribute if rich patients plan more advanced directives or suffer more existential distress. Another possibility is that clinicians dislike controversy and want to avoid appearing callous towards the poor. Right, so this is another factor to take into account. And bear in mind, this is all kind of like speculation at this point. These are all just like, they're trying to interpret their data, trying to come up with reasonable explanations as to why they're seeing what they're seeing. 1 second. They're not saying that this is the case, but they're just saying that these are reasonable hypotheses that definitely require further investigation. It could also be that the issues that lead people to suicide are more easily solved if it's due to their socioeconomic. I'm not 100% sure what you mean by that. Yeah. Be able to clarify, because I'm not 100% sure what you mean by that. Okay. I don't know that I would trust an economist to work with a population that might be applying for medical assistance dying. Our study does not determine the appropriateness of medical assistance dying, and for many, the choice is unthinkable. So as in addition to the argument against medical assistance dying on the panel that I already went through, of the concern that it was expressed is this is going to be a first line kind of treatment or option, when clearly it's not. And also the other sort of argument broadly put forth that I interpreted was this is just an excuse to wipe out poor people. And maybe this is a moderating factor, where it's if a doctor knows, okay, that their patient is coming from a lower, or if their healthcare team knows that they are coming from a lower socioeconomic background, okay, and so that isn't the greatest optics, right? Where it's this person has a terminal illness. You might just be using that as an excuse to kill poor people, right? Who wants to deal with that type of optics? Or it's understandable why a clinician would not want to, deal with those types of optics. Whoops. The observed unequal treatment might also reflect fallible intuition. The thick-skin bias describes a tendency to perceive individuals of lower income as less distressed by negative events, and reflects an implicit belief that repeated hardships lead to increased tolerance. Let's make your problems come from poor and then solve material. Okay. Then I understand what you mean. Where it's like, yeah, you know, uh, your thoughts towards dying, might change if you were, if your material conditions were better, right? You may very well not even apply for medical assistance to dying if your material conditions were better. Then I understand what you mean, and that's totally a possibility. Did they look at percentage accepted? Right. Yes, they did look at. Well, they looked at accepted amongst those who are in palliative care. As I alluded to earlier. Or do you actually specifically mean accepted, right? Because I don't think they tease out like this number of, because like you have to apply for this, and therefore it has to be approved, and there's like a process to go through. It has to be approved by, I think, at least 2 other medical professionals. So I don't think they cover those who were rejected, but those who were accepted. Yeah, so it's like 50,000 palliative care patients died, and 920 received medical. So 920 were approved, but they don't say how many apply. So presumably, a certain percentage was rejected, right? And that would be probably good data to collect. Like, what is the socioeconomic background of those who were rejected? May not have good data about that. They even mention. They don't even mention rejected. Where was I? Yeah, this thick skin bias. Similar to other implicit biases, this error might originate from a common assumption. Specifically, people sometimes adapt to difficult situations, shift their expectations, and increase their tolerance. The intuition fails, however, when hardships lead to resignation instead of resiliency. In effect, the chronic stress of poverty might not buffer against the added challenges from ill health. Such fallible intuitions might add to a paradox of lesser care despite serious clinical needs. Like, yeah, I think, well, they're not saying that this is the case, but I think they're highlighting here something really important. Yeah, exactly. That's totally fair. Or at least, it's, well, this is not... Let's not totally, I guess, dismiss the challenges of those who have material security. Because, like, those who have material security, they can experience hardships and all that stuff. I'm like, oh. And obviously to be transparent, even though I personally, I'm not in a high socioeconomic background, but I have a decent amount of material security. Like, I'm in a pretty good family situation. I'm in a fortunate family situation. But like, yeah, totally. Anyone across, regardless of your socioeconomic background, can suffer. Yeah, exactly. But do they look at what proportion of people are accepted by income group? That would answer many of yes, I agree with you. That would answer many of their hypotheses. As far as I can tell, they do not gather that data. But let's look, actually. I can't remember. What is their methodology? Methodology is here. Yeah, methods. Okay, so most Canadians, adults, strongly support medical assistance in dying, as indicated by national opinion polls conducted in recent years. This support is nearly as strong among poor households. So, poor is less than 40,000 Canadian annual income, and rich households greater than 100,000 annual income. Yeah, the Supreme Court of Canada ruled on basically February 2015 that competent Canadian adults have the right to assistance in dying regardless of ability to pay. And so it's like 2016 when it was like essentially legal. Patient selection. We identified older adults, so over 65 years of age, who died under palliative care using validated linked databases. We included deaths between this date and this date, basically June 2016 to June 2019. All years. Yes. Okay, yeah, so, whoops. I don't know why that. So, since they're basically going by records, and, in databases, like, they are, I imagine this is all, like, coded data. Like, you filter it by age, or greater than 65 years of age, and then, like, we're obviously keeping records of those, received medical assistance in dying. So we're probably not keeping records, of, like, let's say those who are rejected, right? Like, those who are rejected, they don't receive medical assistance to dying. So, like, we're probably not getting the socioeconomic background of those people. And so it would be good if we track that. But, like, yeah, it's kind of like, it's basically like a filtering effect happening. So yeah, these stringent selection criteria undercount cases compared with federal data sources. Right. And so yeah, bear in mind, yeah, it's greater than 65 years of age. And as far as I know, like, you just need to be, like, an adult to apply for this. And so presumably, like, patients under 65 years of age are receiving medical assistance dying. It's just that, based off of this study's criteria, they filter out those people, right? So there's, they have stringent selection criteria. So that introduces, not some bias, but, like, as I said, a filtering effect. So how do they assess the socioeconomic status? We identified a patient's socioeconomic status based on the Statistics Canada official algorithm using the smallest population unit available, about 500 persons. These estimates reflected home neighborhood location, did not rely on self-report, and were validated in past research. Right. So, like, they were not taking, they weren't taking the person's, word for it. It was, like, their actual income, socioeconomic background. Individuals with missing data were assigned to the lowest quintile to yield a fully comprehensive analysis and more conservative estimate. The purpose of this approach was to avoid limitations in past research, such as sample sizes, subjective survey responses, volunteer participants, blah, blah. The main limitation of our approach was potential random misclassification that would tend to bias comparisons to the null. And, like, yeah, there's clearly a limitation when it comes to sample size, right? Even though, they looked at, 50,000 patients. When it comes to those who actually received medical assistance dying, a small number, less than 1,000. You can't do the most rigorous of analysis with a fairly small sample size. Information on patient age, sex, and home location was based on linked demographic databases. Yes. Clinical characteristics, almost certainly by just, like, medical records. They go through their statistical analysis. Yeah. So basically, it does not look like they look at what proportion of people are accepted by income. So, wrapping up, expanding on the limitations of this study, as every study has limitations. Several limitations of our study merit emphasis for future research. Socioeconomic status measures are imperfect, and to bias analyses towards the null, and may underestimate disparities in care. In addition, disadvantaged groups tend to access palliative care less often than privileged groups, thereby causing our study to underestimate upstream socioeconomic barriers ahead of receiving. Right. That's actually another point to consider. Where it's like, yeah, palliative care is a type of specialized care. And Just as they say, a possible explanation as to why you are seeing a lower rate of medical assistance in dying in poor people might be because they're less able to advocate for themselves in a medical setting. Well, if that holds true, then, it's reasonable to conclude that when it comes to, advocating for themselves for palliative care, there's probably almost certainly, well, given the fact that generally speaking, on average, poor people have less access to healthcare in general. So not only do they have likely less access to palliative care in general, even if they, require it, they're also probably also not advocating for palliative care themselves. And so this might result in an even further underestimation, potentially. Let's see. Yes. We also lacked data on race and patients younger than 65 years, thereby justifying further analyses in other groups. Medical assistance in dying itself has different meanings depending on available alternatives and the patient's own beliefs. The scientific domains of health inequities and of terminal care are themselves complex topics, often guided by moral principles, rather than behavioral economic analysis. Case control analyses are rarely accompanied by a confirmation survey for many reasons. Specifically, surveys are often fallible due to faulty sampling, imperfect response rates, social desirability bias, careless mistakes, or other artifacts that cause self-report to diverge from real behavior. In addition, most surveys merely offer a superficial impression of lived reality, such as the differences between poverty and wealth. The observed discrepancy in medical assistance dying might be explained by the observed discrepancy in judged suffering for rich and poor patients. However, other important contributors could remain. The strength of the confirmation survey was to explore intuitive clinical judgment using a randomized experimental approach. And so to wrap up this study, overall, our data address lingering misconceptions around the medical care implications of the Supreme Court of Canada decision. First, medical assistance in dying has not led to a large drop in palliative care. Instead, rates of palliative care increased during the study. Second, medical assistance in dying has not become widely popular despite being free and legal. Instead, the practice accounts for fewer than 2% of deaths in palliative care patients. Third, medical assistance in dying has not been unjustly targeted towards poor patients. And this was definitely a concern that was expressed explicitly on the panel. I think even Wick himself has this position. I don't want to mischaracterize Wick's position, but that is my understanding of it. Instead, wealthy patients are disproportionately involved. More broadly, the data might inform patient engagement, less extreme decisions where poor patients might be disempowered or clinicians may feel disinclined to push. Right. Because, and again, what doctor wants to be seen? The question becomes, should medical assistance in dying ever be encouraged? Probably not. It should just be, at the very least, presented as an option. But even a physician presenting it as an option, one could argue that even just informing a patient of this as an option is potentially encouraging them, apply for this. And so, how do you do this in an unbiased way? And you shouldn't necessarily rely on a patient, informing themselves of all their rights and all their therapeutic options. And so, at some point, medical professional, where appropriate, should have the ability to just present this as a potential option. But what medical professional wants to, be viewed as, they know that their patient is poor, You don't want to be seen as encouraging a poor person to kill themselves, right? Or to, receive medical assistance time. Because again, those are super horrible optics. Oh wow, Zeron, thank you so much for the sub. Always grateful for your support. And yeah, can never thank you enough. And I hope you're doing well. And so yeah, it's tricky, right? Like, I don't know what the best way is to like have a doctor present this as an option. Well, I'm talking. I'm presenting some of the research. And you're more than welcome to share your thoughts if you want to, but no pressure. So yeah, so this is one study, okay? And this one study, it's a couple years old, not super outdated, and we only have so many years of data to work with. But like, yeah, 2016. But basically, pretty sure the trends pretty much still hold today. But this is just Ontario, Canada. Well, so, this does not necessarily represent all of Canada. This is just the trends observed in Ontario. But it is, like, as they say, the largest... Yeah, Ontario is Canada's largest province with a population of 13.5 million. But we do have this... Right. There's this study as well. So this is earlier. This is 1 year earlier than the one I just presented. Yeah, totally. And if anything, like, at the very least, I want to get through all the research to present everything and to hopefully give, a more clearer picture. So, this is early experience with medical assistance in dying in Ontario, Canada, a cohort study. So yeah, the study that I just showed, it was 2021. Yeah, 2021. This is 2020. And they are specifically, referencing. This is the early experience. When MAiD first came on the scene. And this is by the Canadian Medical Association Journal, CMAJ. So, as they say, medical assistance in dying was legalized across Canada. Well, we already know this, already went through it. So, they pretty much carried out a pretty similar analysis. It's a retrospective cohort study comparing all MAiD-related deaths with all deaths in Ontario. Okay, so here's where it's a little bit different. I'm very much more inclined to this. Yeah, that's totally fair. And I would say these are just as important questions for things to consider. So in the last study that I just showed, they specifically looked at palliative care patients. So basically, patients essentially receiving end-of-life care. Well, so as much as I can totally crap on philosophy and crap on people who get too philosophical and kind of like pie in the sky debates and arguments, there's totally a place for philosophy in my mind, as long as it's grounded in reality. And philosophy is definitely good at coming up with good questions. And but you also have the opposite side of the coin of like philosophy can generate good questions and bring to bear illuminating questions. It could also bring to bear ridiculous questions that just have no basis in reality. balance in all things, as they say. So yeah, this is a retrospective cohort study, and so they're comparing the MAiD deaths with all deaths in Ontario. So it's not just those who are in palliative care. This is pretty much total number of deaths in Ontario. Between this 2-year window, or roughly a little over 2 years, June 2016 to October 2018, clinical and demographic characteristics were collected for all MAiD decedents and compared with those of all Ontario decedents when possible. We used logistic regression analyses to describe the association of demographic and clinical factors with receipt of MAiD. So 2,200 patients were included. Almost exactly half were women. Let's see. And 186,000 in the general Ontario decedent cohort. Recipients of MAiD reported both physical and psychological suffering, pretty much to almost fully 100% before the procedure. In about 3/4 of cases, palliative care providers were involved in the patient's care at the time of the MAiD request. Okay, so like, yeah, here is where this is a little bit different than the last study. Where it's like, yeah, in the last study, 100% palliative care patients. This one, 3/4 were palliative care patients. But still, like, basically, the vast majority of patients receiving MAiD, still palliative care patients. Pretty much just as, the statistics that I outlined earlier, just the overall statistics of MAiD in Canada. Average age is over 70, and like the vast majority are receiving palliative care. The statutory 10-day reflection period was shortened for 26.6% of people. Okay, interesting. Compared with all Ontario decedents, MAiD recipients were younger. Okay, so mean, 74.4. I would still say that's elderly. Compared to 77. More likely to be from a higher income quintile. So like this mirrors, the other study was basically a continuation or builds upon this study here. I should have covered this one first, since it's earlier, but regardless. This basically echoes the same trends, where it's like, we're seeing again, still in Ontario, that generally speaking, those who are receiving medical assistance dying tend to come from a higher income quintile. They're less likely to reside in an institution, more likely to be married, interesting, and less likely to be widowed, and more likely to have a cancer diagnosis, no surprise. And this is borne out in the overall Canada-wide data, where like, yeah, when you analyze the data Canada-wide, the majority of individuals receiving medical assistance dying they have cancer. So, interpretation. Recipients of MAiD were younger, had higher income, were substantially less likely to reside in an institution, and were more likely to be married than decedents from the general population. Suggesting that MAiD is unlikely to be driven by social or economic vulnerability. Given the high prevalence of physical and psychological suffering, despite involvement of palliative care providers in caring for patients who request MAiD, future studies should aim to provide our understanding, to improve our understanding and treatment of the specific types of suffering that lead to a MAiD request. Yeah, that's fair. Like I take your point that socioeconomic status is not necessarily, or it's not synonymous with income, right? But like, I'm curious, like, what other factors do you think play into in socioeconomic status? Like, I would still say, like, built into socioeconomic status, like the largest variable, like, is income, at least in my mind. I could be wrong. Or like the primary variable to be concerned with that's like easily analyzable is income. But I do take your point that there is a potential distinction to be made between socioeconomic status and income. But I would say it's probably more difficult to do that analysis. And I can understand, for convenience sake, for just going by socioeconomic status, or like using income as a metric of socioeconomic status. You think that, and that may very well be true. Like, I obviously don't know the reasons why. In particular, relevance to the study, I'm speaking about the relevance of mental health. Yeah, that's totally fair. But yeah, that's where it gets tricky, right? At least it gets more difficult to analyze, because this is not necessarily the most easily accessible information, as opposed to like income, generally more easily accessible. And also like I would say these are, as a result of stigma, these are like you know, probably underreported, or like, you know, an individual is not necessarily the most willing to share this type of diagnosis, unless you're just like going by strict diagnosis and medical record. Yeah, it's tricky. But you do make a good point. And also, you know, to your point, and also, like, no surprise, as they say, patients receiving MAiD commonly reported both physical and psychological suffering. Or, you know, understandably, one affects the other. Your physical status affects your mental status, or your psychological status, and your psychological status totally affects, you know, there's clearly a dynamic interplay, those two things. Where, you know, and this is one of the reasons why in my own disease and condition, you know, when you look at the rates of, you know, depression, anxiety, etc., amongst Crohn's disease patients, it's like, you know, 3-4 times the rate in the general population. But also at the same time, when you look, there's a dynamic interplay of like, you know, Crohn's disease makes your mental health worse, but then as your mental health declines, also makes the disease worse. So they have generally poor outcomes. There's less treatment adherence. You know, depressed or anxious patients, they don't necessarily, you know, stick to their treatment plan, as, you know, the doctor recommends. And so yeah, it's really tricky. And actually, there was a study, getting a little bit on a tangent, but since, you know, it relates to me specifically, there was a study published not that long ago, pretty much yeah, a few months ago, July 2022, pretty much like covering this topic, where it's like, yeah, just when you look at the prevalence of, as they say, psychiatric disorders amongst patients with IBD, or Crohn's disease and ulcerative colitis, it's generally, almost across the board, higher prevalence. And like, is it the disease causing this, or is it the psychiatric diagnosis, you know, affecting? Anyways, that's a whole other thing that I can talk about for a long time. I don't want to get too off topic. So where was I? Yeah, the median age of MAiD recipients was 75 years of age. Again, this pretty much echoes the overall trends in Canada. Okay, psychiatric consultations were performed in 6.2% of cases. Okay, so interesting. So like, pretty much, in small minority of cases was a psychiatric consultation performed, which I think, you know, at least to me, I think there should be, I think it should almost be mandatory. Like, but I understand that there's limited medical resources, and it's not always the easiest to get a psychiatric consultation. But let's just say, I would say in an ideal world, I think everyone applying for medical assistance dying should undergo a psychiatric consultation. But I understand that that would implement that and enforce that. That likely introduces a barrier, an unnecessary barrier. In 4.3% of cases, the MAiD recipient had been found ineligible for MAiD on a previous request. Oh, okay. Now we're getting a little bit more data into, like, you know, application process. As I see it, there's nothing problematic about MAiD for those who are already dying from a chronic condition. Yeah, I'm pretty much of that same mindset. When intangible factors so heavily something as serious as MAiD, their lack of quantifiability must be addressed. Well, I believe the majority of progressive arguments against MAiD are concerned primarily with this minority of cases. Yeah. I think that's true as well. And also, welcome back, Boy Meets Minion. And also, thank you for returning, and also congratulations on your new lap time. And I'm not going to take no. That's all you. I have no effect on your racing. You deserve 100% of the credit. So yeah, it seems like you can apply multiple times. Like, I wonder, I have to look into this, but I wonder, like, if you apply and get rejected for MAiD, is there like a waiting period before you can apply again? I assume there's a built-in waiting period of, like, you know, if you apply and you're rejected, you have to wait at least like 3-4 months. Apply again, or something like that. In 36.3% of cases, the MAiD recipient had a pre-existing clinical professional relationship with the MAiD provider or one of the assessors. Okay. So yeah, like, basically, in about a third of cases, like, the person who's receiving MAiD, they have a good relationship with a medical professional. Or the one who is specifically carrying out or providing the medical assistance to dying. Which, you know, ideally, you know, again, in an ideal world, virtually 100% of the cases should have some sort of, like, pre-existing clinical professional relationship with a MAiD provider, right? Because, like, at least there's like some degree of trust, and like there's hopefully there's less likely to be any sort of, like, coercive aspect, and, like, you know, the doctor can be confident in the patient's decision. They're in a better position to assess the patient. But again, I understand, like, to enforce that, or to have the expectation that every single case who's receiving MAiD have, like, a pre-existing, you know, good relationship with the medical professional who's providing it. Unrealistic expectation. Let's see. Prognostic estimate of remaining life was not recorded for 56% of MAiD recipients, but it was 6 months or less for 883 patients. Okay, so basically, it seems like, if I'm understanding this correctly, for basically 90% of the cases, like, it was basically, you know, they were given 6 months or less to live, or in all probability, 6 months or less. Medical assistance in dying was performed by a physician in 94.4% of cases and by a nurse practitioner in 5.6% of cases. So, like, yeah, actual doctors, overwhelming majority of cases, are carrying out the assistance in dying. Let's see. I mean, this is pretty much... yeah, as they say here, neither palliative care nor psychiatric consultation is mandatory in Canada for patients who request MAiD. And although some have argued for and against mandatory psychiatric assessments, the shortage of psychiatric specialists in some regions could make this requirement a substantial barrier to accessing MAiD. Right. Oh, again, interesting. Never had this. One second. Apologies for that. So yeah, pretty much like I was mentioning earlier. Like, in an ideal world, like, every patient that applies for MAiD would receive a psychiatric evaluation. But, to have that mandatory, that is, like, a substantial barrier to accessing. What would you say are the main concerns you hear people aiming against? Do you think the type of concern differs based on one's political? Since I was on a panel, saying that, well, I wouldn't say discussing, debating this unproductively. The main argument is like this is just sort of, this would be a way to like get rid of poor people, or an excuse to get rid of poor people, or that this would disproportionately affect poor people. Or pretty much the other argument is like, you know, this will be like a first line go-to for anybody. Like, you know, other options wouldn't be presented, and like if you know, if a patient has like the whim of like, I want to receive medical assistance dying, they'll get it. Is there a place you can find medical datasets like this? Which medical datasets are specifically referring to? Like the ones outlined here, these characteristics? I don't think so. At least not outside of a study. Data. Alright, so, overall interpretation. Well, so what I would say, I mean, I tried to present some of this data on the panel. Like, I specifically, tried to present this data on the panel. Nobody was really having it. But like, yeah, I tried to, you know, dismiss the concerns of like, you know, oh, this is just an excuse to like get rid of poor people, or like this will significantly affect poor people. And like, I would agree with you. The data don't bear that out. Where it seems like, at least on average so far, like poor people it seems like they don't have enough access to medical assistance dying. They appear to be receiving it at, I would say, a pretty significantly lower rate. No, well, since depends on which, like, if you just want raw statistics, since generally speaking, medical data, understandably, is like pretty private. Like, I understand data is different than medical record. And like, you can present aggregate data, but I just don't think, yeah, I don't think you can have, not sure you can have that type of data like just readily available online. Or at least, well, actually, no. I know one of the reasons. So, one of the reasons why you wouldn't have sort of like large aggregate medical data in Canada is because there is no unified medical record keeping in Canada. Since healthcare in Canada is a provincial jurisdiction, as in each province handles its own healthcare, and so you're not going to get like this unified Canada-wide data. And even then, like, I can only speak for my province, Quebec. Like, medical record keeping in Quebec is pretty awful. Where it's like there doesn't even appear to be a unified system within provinces. I can only speak to mine. But it's amazing to me that, like, I go visit my specialist at, like, you know, the hospital that I've been going to for like decades now at this point. I'm like, you know, they're taking records, it's being recorded in the electronic medical records. Like, I'll go see, you know, a general practitioner in like a private setting, and like I'm starting from a blank slate, basically. It's like, oh, what medications are you on? Like, you don't have access to like my medication records, since like my electronic medical records are just affiliated with this hospital network, and it's not throughout the entire province. That's a problem. I think that's a problem. So in this study, comparing people who received MAiD in Ontario up to October 31st, 2018, with all decedents, we found that people who chose MAiD reported physical or psychological suffering as the primary reason, despite engagement of palliative care in about 3/4 of patients, which suggests that for many patients, MAiD requests were not because of poor access to palliative care. Recipients of MAiD were younger, had higher income levels, were substantially less likely to reside in an institution, and were more likely to be married than decedents in the general population, suggesting that MAiD requests are unlikely to be driven by social or economic vulnerability. Well, you're not wrong there. And as much as I know that it's probably a futile attempt to bring data to a panel, I'm still gonna try. I'm an eternal optimist. Like, well, what is choice when your material conditions or when your material needs aren't being? So, palliative care clinicians. Sorry. A previous population-based cohort study that compared the demographic characteristics of 1,300 Swiss citizens undergoing MAiD with Swiss national census data over a 5-year period found that MAiD recipients were both more wealthy and highly educated, and less likely to be living in an institutional setting than decedents overall. So, like, yeah, just like the other study mentioned, we have similar data coming from countries that also have, you know, their own form of medical assisted dying. And we're observing, if not similar, if not identical trends, where it's like, you know, those who are receiving medical assisted dying, they're wealthy, they're educated. However, the Swiss context differs from that of Canada in that only self-administered MAiD is permitted, not physician-administered MAiD, and reporting of MAiD cases is not mandatory. Comprehensive data about MAiD recipients in the United States, Belgium, and the Netherlands have been available for more than 2 decades. Recipients of MAiD in those jurisdictions had cancer slightly more often, and cardiac and respiratory disease less often, than MAiD recipients in Ontario. To our knowledge, there is no publicly reported statistical comparison of socioeconomic differences between MAiD decedents and general decedents from these jurisdictions. Requests for MAiD can be emotionally difficult for patients and family members, and administratively burdensome for clinicians who are helping their patients navigate the assessment process. Any perceived delays can be upsetting for patients, families, and clinicians alike. Reassuringly, only 6.6% of families reported difficulties with access to MAiD, and the frequency of these reports was not affected by socioeconomic or demographic factors, nor were they more common among patients who were assessed or followed by psychiatry or palliative care. Palliative care consultations are one means of ensuring that patients requesting MAiD are aware of the alternative ways to treat suffering, and psychiatric consultations can help to determine whether some patients are capable of making the decision to have MAiD. Neither palliative care nor psychiatric consultation is mandatory in Canada for patients who request MAiD. Yeah, alright. That. The involvement of palliative care providers in the assessment and provision of MAiD, some patients who MAiD, is noteworthy. The World Health Organization's definition of palliative care excludes MAiD, and the International Association for Hospice and Palliative Care has argued that palliative providers should not be involved in the practice of MAiD, and that no country should consider the legalization of MAiD until it ensures universal access to palliative services and to appropriate medications. I mean, I don't, there's part of me that wants to agree with this, where it's like, yeah, in an ideal world, palliative care would be universally accessible to everyone in each country. The same thing where it's like, I think everyone should also have like a base minimum standard of material conditions. And that in an ideal world, you should only, approve or have made legal when all of your citizens have some base level standard of material conditions. But I don't think or to wait until that happens. It's a little bit bizarre to say, but it would be great if 100% of the individuals receiving MAiD were from, none of them were poor, that they were all, at least reasonably wealthy, and were highly educated. Internationally, the relation between MAiD and palliative care providers ranges from synergistic and cooperative to conflicted and opposed. Some palliative care providers in Canada believe that MAiD is an important part of their clinical practice and have integrated MAiD with the provision of palliative care. Others have expressed concern that confusion between MAiD and palliative care might discourage the adoption of a palliative approach for those who could benefit. Our data do not support or refute either position, but as in other jurisdictions where MAiD is legal, we found that most MAiD recipients were followed by a palliative care clinician before death, whereas only a minority of Ontario residents are followed by palliative care clinicians before they die. This may allay fears that people are turning to MAiD because they cannot access palliative care. It may also suggest that people may be seeking MAiD to alleviate a type of suffering, for example, existential distress, that may not be effectively treated by palliative care clinicians. Question is, do the people implementing MAiD and similar policies have this basic understanding of systemic issues? I would say, unfortunately, probably not. I think as we all know, or most of us know, the demographics of the people who are, implementing or shaping this policy don't really reflect the demographics of the general population. Another common concern about the legalization of MAiD is the potential for people who face social or economic vulnerabilities to be pressured into MAiD. However, our data indicate that people from traditionally vulnerable demographic groups, from an economic, linguistic, geographic, residential perspective, were far less likely to receive MAiD, consistent with findings from the US and Europe. And Leviticus, welcome. Thanks so much for passing by. I personally haven't covered any of the, I've only seen a few things. But if what you say is true, and that does seem to be the case, does that surprise me? No. That doesn't surprise me. I think I was more or less under that impression before these Twitter files. I would say anybody operating with the impression that the government is not in bed with social media companies was probably being a little bit naive and couldn't need the Twitter files to come to that conclusion. But to each their own. Whether this reflects a lower desire for MAiD in these demographic groups, or a broader lack of access to end-of-life options for vulnerable Canadians in general, is not clear. As as you alluded to earlier, Theron, it's like, socioeconomic status more than just income. And as they just say, you know, linguistic, geographic, or residential perspective. And like, so like, it seems like the demographics, it's not from traditionally vulnerable groups. Yeah, based off of what I skimmed through, like, yeah, it, as Bob Marley, I think you took the words right out of my mouth, like more or less like a nothing burger. But how do you feel about government officials? Well, I don't feel good about it. Just like, I'm not gonna say I feel good about the U.S. government being in bed with social media companies. But it's like, I don't necessarily know, how to solve that. Or like, I don't necessarily know what the solution to that is. Other than like, question is why can government be so corrupt? Let's see. Yeah, we do not have data about physical or other disabilities, although only 6.3% of the MAiD cohort resided in an institution, compared with 28% of Ontario decedents overall. Our data cannot exclude the possibility that people experience pressure to receive MAiD, or that this led to MAiD in individual cases. Right. Like, even though, as outlined in this study, and in the last study that I showed, like, generally speaking, on average, those who are receiving MAiD, they are basically richer and more educated. But there are still poor people who are receiving MAiD. And it is still possible that though those who are in basically lower socioeconomic status, they may still be receiving pressure. But obviously that's not going to be reported, right? Because they don't collect that type of data. Oh, and thank you so much for passing by. And be well and take care of yourself. And hope to see you again soon. Or if anything, if you're streaming tomorrow, I will almost certainly pass by your stream tomorrow. Let's see. I believe the American citizens are far, far, far too optimistic about how functional their democracy is. I would even extend this to Canadian citizens as well. Even though I do think our democracy functions a little bit better than the United States. Like, I don't think it's like, worlds better. I don't mean the conspiratorial election for... yeah, I know you don't mean that. Yeah. Supreme Court of the United States and the Supreme Court of Canada. The Senate of Canada as well. Like, there are huge problems with that. Okay, well, yeah, don't get me started on the Constitution. But let's just say I definitely have my thoughts on the Constitution. I'm not for the abolishing of the Constitution. But I'm totally for revising it, even though, like, I know that's, like, virtually impossible, or, like, it's super difficult. Same thing with, I think the Canadian Charter of Rights and Freedoms in Canada, or the Canadian Charter of Rights and Freedoms, is, like, pretty good. And I think, I think it allows for greater flexibility. Basically, what I would say is, like, the Constitution, like, it has its pros. Its pros is that, like, there are foundational principles built in that are basically, like, appear to be unmodifiable or unchangeable. And, like, I can see that as a good thing, but then there's the opposite end of, like, you're too rigid, that there's almost, like, no room for change. I equate this. If I were to treat, like, the United States, or even Canada, or just, like, a country as a person, having something like a constitution that is basically, like, unchangeable, or, like, almost impossible to, like, modify or revise, I would call that sort of like a built-in psychological rigidity, or a lack of psychological flexibility. where it's like, gonna bring up, going on a little bit of a tangent. Where it's like, psychological flexibility, basically, to not be cognitively or psychologically rigid, where it's like you don't have these unbreakable rules, okay? It's like to have unbreakable rules, at least at an individual level, can work against you. Where it's like you are too rigid. And like over the course of your lifespan, like your rules need to change in order for you to like adapt to the times at an individual level. This is why they talk about psychological flexibility. Where it's like you're able to go with the ebbs and flows of like your lifetime, and you're able to adapt to your conditions. And this is a concept of like resiliency, of like you're adaptable, you're modifiable, you're not so flexible that like, you know, you're just at the mercy of every whim, but you're not so rigid that like, you know, you're just like unchangeable, and that like no matter what, you're not going to alter your course. You need to know when to course correct and modify, you know, your operating rules. The best analogy that I can come up with, is like, it's like a palm tree. If you've ever seen like hurricane footage and you see palm trees, like palm trees, they're not this super rigid thing. Like when you see palm trees blowing, like in a hurricane, like they're flexible. Like palm trees stay rooted, because of their built-in flexibility. They're not so flexible that they fall over, but they're not so rigid that they snap. That is how I view the Constitution. Where it's like you have this Constitution and you just have this built-in rigidity, that will, on a long enough timeline, going to cause conflict and problems. And I think you're seeing that play out currently. But sorry for the tangent. Getting a little bit sidetracked. Where was I? Yeah, a constitutional convention would be nice. And I think if I remember correctly, like during the drafting of the Constitution, I think it was like Thomas Jefferson who was like advocating like, yeah, every like 20 years you should like revise the Constitution or like rewrite it, something to that effect. And that was like rejected. No, we're going with this. And that like it pretty much impossible to revise. If I could snap my fingers and abolish one Canadian law, would be, yeah, I don't necessarily disagree. Like, yeah, it's tricky. I don't think the notwithstanding clause is universally bad. Like, I understand why. Like, I know the history of the notwithstanding clause, and it was basically implemented, kind of like appease Quebec. Yeah, but you need like 75% of the vote to end the Constitution. Anyways, it's actually hard to. Yeah, exactly. But even 70, like I would say, yeah, that's a whole other can of worms that I don't want to touch right now. Like I understand you can modify the Constitution. I'm like, yeah, the 75%, but like that basically makes it impossible in my mind. That could also apply to behavioralist therapies on children. They often force a flexibility. Yeah, like obviously, well, unfortunately, sadly, any sort of like psychological therapy, and unfortunately, be used to exploit the vulnerable, for sure. I'm not going to dispute that. So where was I? Yeah. Wrapping up this study, the limitations. The MAiD cohort consisted only of completed cases. Available data from other Canadian provinces suggest that as many as 20% of all patients who request MAiD die naturally or they receive it. Interesting. So like, yeah, pretty much exactly 1 in 5. It is plausible that such patients may have been more likely to have encountered difficulties accessing MAiD before their natural death. And so our data may not be an accurate representation of the overall patient experience. The new national reporting system in Canada monitors requests for MAiD, and the future data analysis may provide better insight into access. Reporting of completed MAiD cases is mandatory throughout Canada. It is possible that some cases were not reported, but given the limited availability of the medications used to perform MAiD in Canada, for example, intravenous propofol, this is basically, the heavy, I think it's a hypnotic technically, but it's basically, strong sedative. And neuromuscular blockers, this propofol often used in general anesthesia. Neuromuscular blockers that are generally unavailable to healthcare providers outside of the hospital and MAiD process. Delivering MAiD without record would be very unlikely. The practice of MAiD may vary across the country, and our findings may not be generalizable. However, we have no reason to believe that the main findings of this study related to equity and the involvement of palliative care would be meaningfully different in other parts of Canada. A number of important patient characteristics were not routinely recorded, for instance, religion, ethnicity, or education, which would have provided additional information about the early cohort of MAiD recipients in Ontario. Difficulties with access were reported by a third party, family, friends, or clinicians, post-mortem. These reports may not have represented patients' experiences accurately. Finally, the general Ontario decedent cohort included the patients who died from MAiD. However, MAiD patients made up only about 1% of the cohort. I believe that letter is in dispute. I don't think, and also, I know this quote from the movie The Rock. John Connery's response is patriotism is a virtue of the vicious, according to Oscar Wilde. That's the rebuttal to that quote. Yeah, that's totally fair. Major increase in PTSD risk, clear similarities to gay conversion. I know that the history of psychology is very dark. And well, there's even some recent history psychology that's pretty dark. So, wrapping up this study, the conclusion. The practice of MAiD in Ontario is most common among elderly, community-residing patients with cancer, neurodegenerative disease, or end-stage organ failure, or in the final months of life. Our findings that Ontario residents who receive MAiD were frequently already followed by palliative care providers suggest that MAiD requests are unlikely to be the consequence of inadequate access to palliative care in Ontario. Recipients of MAiD in Ontario were younger, wealthier, more likely to be married, and substantially less likely to live in an institution than the general population of decedents, suggesting that MAiD is unlikely to be driven by social or economic vulnerability. Right. The data presented here do not address the moral question of whether any amount of suffering can justify the hastening of death. However, the growing trend toward legalization and use of MAiD in many parts of the world should prompt the healthcare and research community to improve our understanding and treatment of the type of distress that leads to a MAiD request. Furthermore, jurisdictions considering legalization of MAiD might find data from countries like Canada that have taken this step more recently useful in informing their decisions about legalization of and necessary safeguards for MAiD. But this study echoes this study. Higher socioeconomic status, and generally more educated. So this is some of the research and data about medical assistance in dying. Although this is largely been focused in Ontario, although I did show some statistics about across Canada. But now, to at least demonstrate that I understand some of the concerns from the other side, where this study came out. Not this study. This story came out about, it looks like, or they almost explicitly say, their decision to um, apply and receive medical assistance dying was like driven by their basically economic standing. Well, I'll wait and see. So far, like I mentioned, I've been largely unimpressed with like any of the Twitter files, based off of what I skimmed through. So, Winnipeg woman who chose to die with medical assistance said struggle for home care help led to decision. Right? So like, even though, like I just went through some of the data, the background of those who are receiving medical assistance dying tend to be wealthier, highly more educated. But then there's this story like this, where it adds some justification for the people who are concerned that like, oh, medical assistance dying may just be an excuse to like kill poor people, or kill people who are vulnerable or disenfranchised, in multiple ways. So, it was not a genetic disease that took me out, it was a system, wrote Satya Dara Kovac, who had ALS, or commonly known as a Lou Gehrig's disease, which is essentially kind of like a neuromuscular condition. Satya Kovac, 44, chose to die this week, even though she didn't want to go just yet. The Winnipeg woman's death was facilitated by professionals through Manitoba's Medical Assistance in Dying program. Kovac lived with amyotrophic lateral sclerosis, a degenerative disease that took her mother, grandmother, and uncle. Her condition was worsening, but she felt she had more life to live, just not enough home care support to do so. Yep, that is exactly the ice bucket challenge thing, 100%. Or like, basically, it's just a progressive disease, where essentially you just progressively lose motor function. Well, there's a whole host of other things that happen, but a large part of it is like, over time, you lose motor function. Ultimately, it was not a genetic disease that took me out, it was a system, Kovac wrote in an obituary to loved ones. There is a desperate need for change. That is the sickness that causes so much suffering. Vulnerable people need help to survive. I could have had more time if I had more help. Right? So this is a story, but like, it's a real person that needs to be taken seriously. Where like, as I went through like some of the data on the whole, based off of the data, it doesn't seem like those who are receiving MAiD are disproportionately coming from vulnerable groups. But at least, we have n equals to 1 of like, it does appear to be happening, that, this person, since as a result of their material conditions, and, the challenge, in, accessing some base level material conditions, it is like driving their decision to receive medical assistance dying. Yes, exactly. Stephen Hawking totally had ALS. Although, if I remember correctly, like, they're kind of like an outlier since they had quite a long life. I think if you compare the average life expectancy of those with ALS. So, on Monday morning, support worker and friend Shayla Brantnell rubbed Kovac's head as she took her final breaths at home in her sunroom, surrounded by a small group of people and things that brought her comfort. A photo of her dog, candles, crystals. But according to Kovac's own obituary, statements she made to the Winnipeg Free Press, things she shared with friends, she had grown exhausted at her failed efforts to get more help with basic needs at home. And that is what drove her to access a medically assisted death. It's hard because mentally she was there, She accepted the changes in her body, but without enough support, how could anyone keep going? Said Brownell, who supported Kovac 3 days a week over the past year and a half. And like, understandably, these individuals with this condition, like, they require support, and they need access to the support for like their daily functioning. You're constantly stressed, you're constantly struggling, like, how am I going to get to the bathroom? How am I going to eat food? That's not really a great quality of life either. Kovac lived alone at home with her dog. She didn't want to give that up to live in a facility, said her friend Janine Legal. She said Kovac did not tell the panel of professionals who assessed her application for a medically assisted death that she was driven to seek MAiD due to a lack of adequate home care support, fearing that if she shared her full rationale, they would deny her. Right? So, like, and here's where it gets super tricky, right? We're like, as I just shown in the data from those studies, where it's like, you know, the main conclusion is like, at the very least, those who are receiving MAiD doesn't appear like they are coming from a lower socioeconomic status background. And yet maybe one of the reasons, like multiple reasons, but maybe this is part of it. Like, they're filtering themselves out. Where it's like, they don't want to say that part of their decision is like their material conditions, because that might lead to them being rejected. And so, like, if you really want to get approved, well, then it's in your interest kind of not so transparent about your reasons, or like only give the justifiable reasons that, you know, maximize the chances that you'll be approved. Her death was imminent in the sense that she had ALS, so she would have died from that at some point, but she could have been around for several more years, living a good life. It's really painful for me to think about the fact that she is gone because our society doesn't focus on giving people what they need. Absolutely. That is definitely my sentiment as well. The Winnipeg Regional Health Authority said alternate supports are explored before MAiD is granted to applicants. Applicants have to have a serious and incurable disease, illness, or disability, an advanced state of decline that is irreversible and that is causing intolerable suffering, health authorities said in a statement. It confirmed Kovac met the eligibility criteria. Kovac received 55 hours of home care support per week. As her condition deteriorated over the past 5 months, Legal says her needs increased. And like, you know, the unfortunate part of the condition is like, it's a progressive condition. And like, basically only projected to get worse over time. And as they allude to here, like, just over time, she required more and more support. It was suggested to Kovac that she seek home care help beyond what was provided to her through the public system, but she could not afford the added costs, Legal said. In an interview with the Winnipeg Free Press, published after her death, Kovac said the province and ALS Society advised that she would receive around-the-clock care were she to move into Riverview Health Center. Kovac said she preferred to remain at home, and that she knew others who died shortly after moving into long-term care. Right, and it's also, like, understandable. Where it's like, obviously, I've never been in that position, but trying to kind of, like, understand the scenario as best I can of, like, you know, moving into a long-term care facility. You know, you are kind of, like, giving up some of your independence and autonomy. And understandably, not everyone wants to, like, fully give up their independence and autonomy. Or, like, move into, you know, basically, you know, a new space. I can say for myself, definitely, you know, I have a chronic illness that is very much different from ALS. Like, I can speak on, you know, some portion of those with the chronic illness. Like, at home, like, you have a certain setup. It's a familiar setting. And like, when you're sick, and when you're focused on, like, taking care of yourself, you want to kind of, like, have a home base. where you feel most comfortable. And I can only imagine, or I know that that would be difficult to give up, or like to give that up, to just go into a brand new space that's unfamiliar, that you need to readjust to. That's not an easy task. So, Kovac felt humiliated by the process of asking for and failing to obtain adequate home care services. Well, she cared about neighbors and people and community, and she wanted others to care too, and sometimes that didn't happen. So she was very hurt by that. The leader of Manitoba's opposition, NDP, said Kovac's experience underscores the need for more investment in home care services. He did not have the right home care services, Wab Inu said during question period Tuesday, asking Mayor Heather Stevenson what her progressive conservative government is doing to fix home care in Manitoba. Stefanson said seniors and long-term care minister Scott Johnston is looking at revamping and improving home care, with that review including how to address staffing shortages. We recognize that there is more work to be done, Stefanson said. That's exactly why we set up the Ministry of Seniors. Nancy Hansen, a professor and director of the Interdisciplinary Master's Program in Disability Studies at the University of Manitoba, said the case highlights serious issues with how expanded access to medically assisted death is being offered to people with disabilities. And Desolate Mirror, welcome. That's the PCC. Progressive, it's an oxymoron. It used to be... the CPC. Which, that's, let's say, more transparent. Or, like, more on the mark. Progressive conservative just, like, muddies the waters. It basically is just like the Conservative Party of Canada, just rebranded. Although that's like that's they're talking about at a provincial level, but it's the same thing at a provincial level. Prior to February, when MAiD was expanded to people with disabilities, an applicant had to be facing imminent death, said Hansen. No, you can... I mean, C is right next to V, so I don't think that's a huge blunder. So, I mean, basically, if you're talking about federally across Canada, the Conservative Party, it does get a lot of votes, because, like, generally speaking, the trend is, like, in the East, so, like, Quebec, Ontario, and like Saskatchewan, but basically, just as the U.S. is kind of split between blue and red, the same thing in Canada. It's like our federal elections. It's basically between the Conservative Party and the Liberal Party, and they get millions of votes. And just this most recent election, it resulted in a minority Liberal government. And so totally, they do get a lot of votes. Although, to be fair, one could argue that the Canadian Conservative Party, or the Conservative Party of Canada, is like it's pretty close to the Democratic Party in the United States. Like, basically, even though Canada's Conservative Party is like relative to Canada, it's right-leaning, it would be kind of like centrist. Maybe if you squint enough, it'd be like left-leaning. You compare it to the United States, and like their right-leaning parties are so right that our Conservative Party looks left to them. Like, I mean, the Republican Party is just like so right wing, That is just, like, off the charts. So I don't understand why society is so anxious to see death as dignified as related to disability. And yet a society will not provide appropriate resources for people to live with dignity. Hansen, who is disabled. We provide funding as a society for the elements that we value, and it seems to me that there's a lack of worthiness and a lack of value placed on disability. I'm like, yeah, as someone with a disability, an invisible disability, I totally echo this sentiment. We're like, you know, as much as I support MAiD, and I'm glad that we have access to it in Canada, like I don't support this. Like, this should not be happening. Someone applying and receiving MAiD, it should be driven by a medical need, not their material conditions. And it's like, basically, this reflects poorly on Canada. Hansen said medically assisted death is a sort of a simplistic solution to something that requires more creative thinking. Legal says she regrets not mounting a more robust advocacy campaign for her friends sooner. I feel like her voice wasn't being heard. Taught me a lot about the value of life. So like I said, even though I presented data, and like the data on the whole seemed to show that generally speaking, you know, those who receive medical assistance dying come from a higher socioeconomic status. But it does still seem to be the case that there are cases of people who are receiving aid, and it's like an economic decision or like a result of their material conditions. And there's another story. There is this story here. This was published fairly recently, if I remember correctly. Within the past 2 weeks, I think. No, I'm wrong. Past 6 months. This is May of this year, where a woman with disabilities nears medically assisted death after a futile bid for affordable housing. And this Winnipeg woman, they were quite young, 44. And this person's even younger, 31. A 31-year-old Toronto woman who uses a wheelchair is nearing final approval for a medically assisted death request after a fruitless bid to secure an affordable apartment that doesn't worsen her chronic illnesses. The looming approval for death surprisingly makes her grateful, relieved and elated, he said in an interview with CTV News. I was scared that they weren't going to say yes. Denise asked us not to use her real name to protect her identity. She was diagnosed with multiple chemical sensitivities, which triggers rashes, difficulty breathing, and blinding headaches, called hemiplegic migraines, cause her temporary paralysis. The chemicals that make her sick, said Denise, are cigarette smoke, laundry chemicals, and air freshener. She is at risk of anaphylactic shock, so has EpiPens at all times in case she has a life-threatening allergic attack. Denise is also a wheelchair user after a spinal cord injury 6 years ago and has other chronic illnesses. So like, they require pretty significant, medical support. Applied for MAiD essentially because of abject poverty. She desperately wants to move to an apartment that's wheelchair accessible and has cleaner air, but her only income is from Ontario's Disability Support Program. She receives a total of basically $1,100 a month plus $50 for a special diet. She's $1,200 a month, which, if that is her only source of income, that is, I remember correctly, like below the poverty line. I've applied for MAiD essentially because of abject poverty, she said. One of her physicians, Dr. Rena Bray, medical director of the Environmental Health Clinic at Women's College Hospital in Toronto, has been looking for better housing, saying Denise requires immediate relocation for her safety. But Denise said she and supporters have called 10 different agencies in Toronto over the past 6 months to locate housing with reduced chemical and smoke exposure that she can afford on PSP. None of them were able to do anything meaningful in terms of getting me relocated, getting the discretionary emergency or temporary housing and emergency funds. Denise. Applying for medically assisted death has been surprisingly easier. Which it's like, again, as much as I support medical assistance in dying, it should not be easier to receive MAiD than to receive affordable housing. Again, that's just a reflection, or reflects poorly on Canada. Denise said she began working on applications for MAiD in the summer of 2021. A psychiatrist, she said, first deemed her competent to make the decision. A second MAiD provider reviewed her medical history and signed the approval according to Denise. Another physician who offers medically assisted death has now asked her to finalize documents, including a power of attorney, funeral arrangements, along with a do not resuscitate order. She said she's finishing up this documentation. Denise has also asked doctors to waive the 90-day waiting period for people like her who are track 2 cases, meaning their natural death isn't imminent, hoping for an earlier death. Bray said none of the doctors contacted her to learn about the efforts to help Denise find housing first. This is despite research showing that people with multiple chemical sensitivities often improve in chemically cleaner environments. Shocking, she said. They're easily fixable situations. Where it's like, based off of how they're framing it here, this very much seems like an unnecessary use of medical assistance dying, where it seems like, if there were just greater political will, this individual's issues are solvable, where it's like affordable housing and like greater medical care. Denise confirmed that when friends and supporters can raise money for her to stay at a wheelchair-accessible hotel that's near a ravine with clean air, her symptoms lessen greatly. Days are paid for with donations and are limited in length by how much funds are available. It is an emergency solution and absolutely not sustainable, Denise wrote in an email. Denise says her life today is a far cry from her early days as a professional makeup artist. I was earning $25 an hour. It was a good job, she told CBT News. But chemical exposures from her work triggered her multiple chemical sensitivities, or MCS. MCS is a recognized disability under the Canadian Human Rights Act. It's believed to be caused by exposures to chemicals or other environmental exposures that cause physical symptoms, although it is a controversial diagnosis in the medical community. Her story is disturbingly similar to one reported by CTV earlier in April. Sophia also suffered from multiple chemical sensitivities. She received a medically assisted death in February after fruitless attempts to get an apartment away from smoke chemicals in her building. Denise said she started the paperwork on her request for MAiD in the summer of 2021, long before Sophia's story went public. This is the tip of the iceberg. Her difficult choice underscores that Sophia's decision wasn't a one-off. Among those trying to help her is David Fancy, a professor of drama arts at Brock University, disability rights advocate. Heard about her plight last fall and attests to how hard Denise tried to get a healthier home, but he's seen her lose hope. Door after closed door after closed door, the gauntlets tend to push people in the direction of the legislation that is there, which is medical assistance and dying, said Fancy, who has started a GoFundMe to try to help Denise find better accommodations. I've got a very significant concern that this is the tip of the iceberg. Devastating, said Devora Obaluk, a senior policy analyst with the Income Security Advocacy Center in Toronto, part of Legal Aid Ontario. She says many people with disabilities are living far below the poverty line, giving them few options. Or it's like, yeah, they're based off of what was outlined earlier in this article, where, this individual was basically receiving, that's like what, $18,000 a year. Well, I don't know how to. No, even less, 14,400. Okay, so like, disability support comes in the form of $14,000 a year, which might be like their sole source of income. And like, you know, when they assess the socioeconomic status of people receiving medical assistance dying, like, and how do they characterize, you know, people with low socioeconomic status? Well, they specifically say, if I remember correctly, poor households are less than $40,000 in annual income. Okay, and like the individual in this story, they're receiving like $1,200 a month, which is like basically $14,000 a year. So like they are basically less than half of how they define poor in this study. Basically, $20,000 would be, you know, half of the annual income to be considered poor, and this person is receiving basically $14,000. They are well below that study's poverty line, which again, that just reflects poorly on Canada, and just like how poorly Canada supports individuals with disabilities. So yes, as they say here, there is an extraordinary cost of living with a disability that is unique to them, and their disability. Wheelchairs are expensive. Therapy, all these things cost extra," said Koblik. But yeah, I totally need to, I can't do that mental math. I don't got economist brain. And thank you for the link, Oily Olive. I'm gonna save it for later. But yeah, like again, as someone with a disability, I can tell you that like, even though, you know, my healthcare is free, not all my medications are free. Not all my medications are covered. And like I totally have to pay extra for some things. Like I don't receive like support for. I'm in a fortunate situation that I can afford these things. But like, and like I'm still able to, you know, work and earn an income, thankfully. But like if I weren't, if I had to subsist on just like 14 or like less than $20,000 per year, like I don't know how I would manage. I would probably have to move in with a family member. Like I almost certainly, or I know certainly I couldn't afford my rent. Let's see. The larger issue of the purpose of medically assisted death in Canada also comes into play. Disability rights advocates. Initially approved by the Senate as a way of alleviating the suffering of those near death, it was expanded in March 2021 to those with chronic illnesses and disabilities. We've now gone on to basically solving the deficiencies in our social safety net through this horrific backdoor. Not that anybody meant it that way, but that's what it's turned into, said David Lepovsky, disability advocate and visiting professor of disability rights at the Osgoode Hall Law School. With the right support, I have no doubt people with disabilities can live well in society. We all want people with disabilities to know that their lives have value. Koblik. CTV News contacted Ontario's Ministry of Children, Community and Social Services, which confirmed the monthly payments to those with disabilities who live on their own. Both Denise and Sophia were assessed at the Environment Health Clinic at Women's College Hospital, which tries to help people with chemical sensitivity. Bray says the clinic is seeing a growing number of referrals for the condition, with a 2-year waitlist for a specialist appointment. Canadian statistics suggest that at least 700,000 Canadians suffer from sensitivity to chemicals. Society is failing these patients. I 100% agree with. In these two stories here, like Canada has failed these individuals. Where it's like, again, as much as I support MAiD, it should not be used for this. that Canada needs to, like, reflect on itself. And like, if stories like this, if stories like these aren't a wake-up call, then I don't know what is. My hope is that we can just put a stop to this very easy out that MAiD is providing and start acknowledging that these people need to be helped. Oh, and Louis 13, welcome. Thanks so much for passing by. So, in terms of rent across Canada, it's gonna vary by region. And definitely times are changing, because like, I know that Toronto is like in a pretty big kind of like affordability crisis. Second, yeah, grim housing affordability. Yeah, if I lived in Toronto, I'd be broke, owning a home. So what I can say for my province, even though the trend is in the wrong direction, and affordable housing in Quebec going in the wrong direction, but generally speaking, the rent in Quebec is typically lower than many parts of Canada. And it's still, like, I would say, affordable, where, like, you can probably get by in, like, a single unit for, like, less than $1,000 Canadian rent. But even then, I don't know how much longer that's gonna last. And I don't know for sure. I'd imagine that since this story was published like 6 months ago, what was the woman's name? Where? I guess they don't. I was gonna, like, just Google search their full name, but I guess they want to give their full name. But I would imagine they've received their medical assistance in dying. Which, like, it's so strange, right? Because, like, in these two cases, well, maybe less so in this one, but at least in this case, it seems like their issues were solvable. They just needed affordable housing, more money. As they explicitly say, they applied for MAiD because of abject poverty. Poverty is solvable. Canada is a developed country, or I would like to think Canada is a developed country. This makes me call into question. Do Canada got something similar to ADA? Americans, yes, definitely Canada has something, like, totally there are disability rights in Canada. I remember struggling watching Canadian. Yeah, no, that's fair. But generally speaking, a lot of the disability rights that people in the United States have, like, they're very similar in Canada. And yeah, well, Canada is trying to build more houses. And what qualifies as building affordable houses in Canada, I would say is not so affordable. Or, like, how they're going about building affordable housing is, like, ass backwards, basically. Oh, that was, so I'm gonna save it for later, because there's still a couple other things that I want to cover.
Yeah, I wish.
Pause. So, like, yeah. So again, despite the data that I showed, where it's like, I showed 2 studies, where it's like, yeah, it seems like the socioeconomic status of people receiving MAiD, they seem well off. But then you have stories like these, right? And you can't ignore these stories. Like, even though this isn't part of a large, these are anecdotes, these are real people. And so, like, it's callous to say, but this is kind of like, collateral damage. And, like, the medical assistance to dying wasn't designed for this. It shouldn't be used for this. And again, it should be like sending up alarm bells to policymakers, where if you have people like explicitly saying, "Hey, I'm using MAiD because of abject poverty," like, gotta wake up. And there was this. Right, okay. So this was sent by Cernu. Also about medical assistance death. So thoughts on MAiD? Yeah, that's tricky. I still think it should be accessible. But this is just like off the top of my head. Thoughts? Oh, Cernu, welcome. Or maybe welcome back. Yes, I want to read this as well. Where it's like, yes, a lot of the suffering, that, people living in poverty experience, a lot of it is driven by poverty, but at the same time, they still have medical needs. Or rather, I still think they should have access to medical assistance in death. But at the same time, like, I wouldn't want the government in a developing country use that as an excuse to, like, not help those who are living in poverty. Just as I don't want Canada to use MAiD as an excuse to not, help those who are living in poverty. Like that's a sad state of affairs. Like Canada should feel sad. So, woman featured in pro-euthanasia commercial. Wanted to live, save friends. So I before reading this, I think I know what this is referring to. Because like, this was out of Quebec, if I remember correctly. And it wasn't, I would say it was not a commercial. Because it was with this company, a local company, Quebec fashion retailer, is tackling medical aid in dying on its shopping website, where pretty much like MAiD, you can call it an ad. I would more call it a documentary. I haven't watched it, okay, so I guess I can't fully judge. But I read this article, and based off of what I can gather, it was more documenting their experience rather than like an ad. Like, it's a fashion retailer, but I don't think they were like pushing fashion or like advertising or promoting medical assistance in death. But I could be wrong. I haven't watched it. So I feel like I'm falling through the cracks. So if I'm not able to access healthcare, am I then able to access the death care? Hatch said in his interview. The woman featured in a glamorous pro-euthanasia commercial for a Canadian clothing retailer only opted for assisted suicide after her years-long attempts to secure proper healthcare failed, have revealed. Jennifer Hatch, 37, so another young person. We have this, 44-year-old Winnipeg woman, and in just that last article, they were 31, Denise, the wheelchair, the multiple chemical sensitivities. Now we have another young person. So like, these look like very much outliers in the overall trends of medical assistance in death, where it's like, if you look at the average age at time of MAiD being provided, the average age is 75.3. And so far we've gone through 3 stories where like they're in their 30s and 40s. Jennifer Hatch, 37, was the central figure of All Is Beauty, a 3-minute film produced by Simmons that celebrated Hatch's last days before seeking medically assistance. Last week, CTV confirmed that Hatch was the same woman who had spoken to them in June about her failed attempts to find proper treatment for Ehlers-Danlos, EDS. So I definitely know Ehlers-Danlos syndrome, another genetic condition, where it's like, EDS can vary along a spectrum, where it's like the mild to very severe and disabling and debilitating. Where, yeah, not only do they have, so as a result of kind of like their connective tissue issues, those with EDS tend to have like very stretchy skin. You can maybe like look up some YouTube videos of like some EDS patients. Like you see them like they almost look like Stretch Armstrong type stretchy skin. But this results in a whole bunch of other like joint and connective tissue issues. And like, yeah, it's very devastating and debilitating condition. But those drawn who have it on the mild side, in addition to like their stretchy skin, if they have it mild, it might just be like they're just like ultra flexible. In addition to some like other minor symptoms. So I feel like I'm falling through the cracks. So if I'm not able to access healthcare, am I then able to access death care? That's what led me to look into MAiD. Hatch told CTV in June under a pseudonym. Oh, sorry, I missed some of this. It was an advertisement in the sense of using a person for brand building, tying themselves to a cause. The Peter Simon interview was even worse than the advert. The company took down both videos from their YouTube page, so their conviction in showing the beauty of care wasn't very... Okay, interesting. If they wanted to celebrate her life, then taking the videos down is... I would agree with that. If they took down the videos, I would say that is not a celebration of life. And I didn't watch the video, so I can't judge. But like, I'll gladly take your word for it, because, I trust you. But I can, given the nature of the subject, these are really difficult things to cover. And I would totally agree. When I first read this story, a little over a month ago, like I read this when it was published, back in November. When I read this, I'm like, this is pretty perverse. Well, hopefully you know me, I'm not pro-corporations, generally speaking. And I found it pretty bizarre that, a fashion retailer, like, seemed to take some vested interest in attempting to document this person's experience with medical assistance dying. And based off of how they were spinning it here, they were saying like, oh yeah, we should have these difficult conversations. Companies should also get involved in these difficult conversations. I'm like, yeah. My reaction to this was pretty mixed, and I thought it was pretty weird. So, like more than 1 million British Columbians, Hatch was left without primary care after her family doctor moved away. And so after her EDS diagnosis 10 years ago, Hatch's treatment had largely consisted of a chaotic and ineffective stream of specialist appointments, none of whom had any background in her condition. It is far easier to let go than keep fighting. Even when it seemed apparent that her condition was terminal, Hatch noted that the BC healthcare system hadn't even been able to provide her with appropriate palliative care. However, BC was quick to approve Hatch's application for MAiD. There were no other treatment recommendations or interventions that were suitable to the patient's needs or to her financial constraints. Reads a CTV excerpt of the MAiD approval issued to Hatch by Fraser Health, the health agency serving BC's Lower Mainland. None of these complicating factors were mentioned in the Simmons ad, which instead highlighted what it called the hard beauty of assistance. The film opens with a caption reading "The most beautiful exit" and features images of Hatch holding a Tofino Beach party just days before her scheduled death date. When I imagine my final days, I see music, I see the ocean, Hatch can be heard saying in a voiceover. Simmons has since removed the ad from its online channels after it was subjected to widespread criticism that it was romanticizing Canada's increasingly problematic MAiD regime. And yeah, I'd be super curious to see ads. Haven't found it yet? Well, yeah, so it wouldn't surprise me. Again, this is a Quebec company, and I've even been I've shopped at a Simmons store. There's actually one not that far from me. And yeah, I'm not gonna get into the Simmons family, but none of what you're saying surprises me, unfortunately. Tama Recker, a friend of Hatch, told CTV last week that her friend was ultimately comfortable with the decision to seek MAiD. That she also wanted to highlight a healthcare system that was very broken. Yeah, totally. Healthcare system is very broken. Not just the healthcare system, like whatever. The government of Canada is also very broken. If it's allowing situations like this, or the situations that we've just gone through, where it's like, again, their decisions are being driven by their material conditions. Part of what Jennifer wanted to do is get people talking. Hatch's case fits into an ever-expanding constellation of Canadians who want to live, but applied for medically assisted death out of desperation after failed attempts to seek care. Last year, BC woman Donna Duncan was able to swiftly receive approval for assisted suicide in an Abbotsford hospital after years of unsuccessful attempts to find treatment for chronic mental health issues. The killing of Duncan so blindsided her family that they referred the case to the RCMP for investigation. It's a phenomenon that is increasingly attracting international attention as a poster child of just how quickly legalized euthanasia can spiral out of control. It is barbaric to establish a bureaucratic system that offers death as a reliable treatment for suffering and enlists the healing profession in delivering this cure. It's a recent New York Times column slamming the lack of Canadian safeguards for. In several more egregious cases, Canadians have even been offered MAiD in lieu of proper medical treatment. Last month, a House of Commons committee heard about 5 separate incidents, linked to something, of Canadian Armed Forces veterans being offered MAiD after seeking assistance with issues ranging from depression to PTSD. Most recently, former Paralympian Christine Gauthier went public with her story of being offered MAiD by a Veterans Affairs caseworker after she complained about delays in installing an in-home chairlift. Madam, if you are really so desperate, we can give you medical assistance in dying now, the caseworker told Gauthier, according to an interview she gave with Global News. Like, yeah, that's actually the case, and I have no problem taking the word for it. Like, that is not how it should be presented. And I'm not sure I have the answer as to how an option like this should be presented. Where, like, again, do we just rely on patients informing themselves of this option? I don't think so. But again, even a medical professional, even saying that this is a thing, introduces some sort of bias, right? Because it puts it on the patient's radar. But I want to see what the 5 separate incidents. Yes, I'm running an ad blocker. Canadian veterans were offered assisted suicide in 5 instances. As many as 5 Canadian Armed Forces veterans were offered medically assisted death by a now suspended Veterans Affairs Canada caseworker. The minister responsible for the department has testified. My browser frozen. Never mind. The case has now been turned over to the RCMP for investigation. Veterans Affairs Minister Lawrence Macaulay told members of the House of Commons Veterans Affairs Committee on Thursday. I've said it before and I'll say it once again. What happened was totally unacceptable. Macaulay told committee members. Thank you. Maybe I've exposed myself. I'm not a true biochemist if I can't even spell biochemistry. But I can totally see the humor in that. Thank you. So, there is no way to justify it. And I will not try to do that today. Or ever. Macaulay said after learning of the revelations, he ordered Deputy Minister Paul Ledwell to conduct an internal investigation, which found a total of 4 cases where veterans were offered MAiD, all allegedly by the same caseworker. So, like, well, obviously we don't like have transcripts of the conversation that took place. Part of me wishes we did have those. I would like to see exactly what was said. And this seems like, if it's all from the same caseworker, it seems hopefully just one bad actor. That number, Macaulay confirmed, does not include the case first reported by the National Post on Thursday, where an active service EAF member, calling himself Bruce, told Tango Romeo podcast host Mark Menke he was offered MAiD out of the blue by a case last November. I mean, yeah, really hard to judge these situations. These are all just reports, kind of like eyewitness testimony. Macaulay said his office had just learned of the case via media reports and urged the veteran, who was afraid of repercussions of coming forward, to contact him personally. The first case made public over the summer occurred on July 21st, where the caseworker repeatedly suggested MAiD to an unnamed veteran who had called seeking help with PTSD and other injuries, telling him that Veterans Affairs had helped other veterans end their lives, and that it was a better alternative to blowing your brains out. Like, those were the actual words said, or anything in that vein. That's totally unacceptable. And like, again, as much as I support MAiD, I don't want these situations to occur. Another instance occurred in December 2021, Macaulay said, involving a veteran asking questions about MAiD, a case previously disclosed to the committee in October. The third case occurred in 2019, where a veteran called Veterans Affairs, specifically asking for information about assistance taking his own life. A case where Macaulay said MAiD was inappropriately raised and was the only time the individual had contact with the caseworker. So it seems like this person was calling or inquiring specifically about assistance to take their own life. And yet it was inappropriately, again. It would be nice to kind of like have transcripts of these. The fourth time occurred this past May, where the caseworker again provided MAiD information to the veteran. Macaulay offered an apology to veterans, explaining they create instances of sanctuary trauma and that the department is restraining frontline staff. I am sorry you had to endure these appalling interactions, and we're doing everything we can to ensure this never happens again. Upon further questioning by committee vice chair Blake Richards, Macaulay conceded that the veteran involved in the December 2021 case has since died after medically suicide. Both Macaulay and Ledwell declined to provide details about the caseworker and weren't able to confirm if she was involved in the fifth case reported Wednesday. Post. Ledwell confirmed the case was only forwarded to the RCMP on Wednesday, but citing privacy reasons declined to say when the caseworker was suspended. After some questioning by Richards, Macaulay confirmed the department had completed investigating the caseworker's previous contact with the veteran. That case, either something was missed in that investigation or there was another employee involved, and now it's a matter of determining which of those two things it is. In either case, that's concerning. Obviously, in the one case, it means your investigation isn't nearly thorough enough, and that it might mean there's a need for an outside investigation. Macaulay said they need to get information from Bruce on his case before making that determination. Both Richards and fellow committee member Luke DeSillett, I guess, expressed surprise at how long this caseworker was permitted to be in a position where she could repeatedly offer MAiD to veterans. You've called it inappropriate. It's potentially criminal because you've referred it to the RCMP. There is at least one veteran who has lost their life because of this, and you're telling me that this isn't grounds to fire this employee, Richards asked. This employee is still employed at Veterans Affairs. That is completely unacceptable. So, I mean, obviously, I'm all for investigating these types of things. And, if in fact it's true, this does seem like, not the appropriate use of MAiD. But this is not to say that, I don't think any veteran, it's not my position that, like, veterans should be excluded from receipt. But, like, I don't really know. I don't know what the answer is to handling this. Especially, like, if it's veterans who are experiencing, severe mental health issues, And if they are, in fact, experiencing, extreme psychological suffering that we don't have answers to. Yeah. So, one of the changes coming to MAiD, starting in 2023, is like part of the criteria. If I can find it in here. I think. Yeah. Okay. Beyond requiring enhanced data collection, Bill C7 sets out two other commitments for parliamentarians and the government. First, it requires that a comprehensive review of the provisions of the criminal code relating to medical assistance dying and medication, including but not limited to issues relating to mature minors, advanced requests, mental illness. Yes. But yeah. I believe in 2023 is that basically currently you cannot, or at least on paper, you're not allowed to apply for medical assistance in death as a result of any sort of mental illness. Or rather, as any sort of mental illness as the sole criteria. Where it's like, currently, if you have like severe depression, or, suffering from severe depression, and, have like a low quality of life, you cannot apply for MAiD. Or rather, you can apply, but you'll be rejected, at least according to the criteria. As opposed to, I believe, starting in 2023, A, mental illness, and B, a criteria, a sole criteria, where you can potentially be approved for medical assistance in death. Safeguards, ability. Disturbing element of euthanasia in this sense is how it renders ambiguity to duty of care. One must petition and argue that it is state's duty of care to terminate the life of a citizen, or even me. How does this impact the way persons with manufactured? Let me read this again so I make sure that I understand fully. A disturbing element of euthanasia in this sense, how it renders an ambiguity. One must petition and argue that it is the duty of care to terminate life. Okay, yeah, so okay. I think I understand what you're saying in terms of like, yeah, you're putting care, or duty of care, or terminating a life in the basket of duty of care. Where it's like, yeah, I understand where it's like a little bit counterintuitive, where it's like ending a life, how, under what, definition use care or duty of care to terminate a life. So like, what does care even mean at this point? And how does this impact the way people think of their fellow citizens with such a manufactured right? Yeah, like I think I understand the sentiment that you're conveying. Where it's just as it's a little bit counterintuitive, where it's like, the healthcare system is, administering medical assistance in death, right? Where it's like, healthcare, generally speaking, the guiding principle, like, saving a life, and like hopefully improving quality of life and treating diseases and conditions. But like, how can healthcare be involved in administering basically death or assisting in death? Like, I agree with you. The traditional concept of healthcare would have nothing to do with medical assistance in death. And I would say this is probably like an evolving form of healthcare in my mind. I understand the pushback, and I definitely know that not everyone agrees with medical assistance death or supports it. And I can totally understand the other side. Trying to find vision where they're changing. Let's. Yeah. Diagnosed with a grievous and irremediable medical condition where a person must meet all of the following criteria. So all of these. Serious and incurable illness, disease or disability, advanced state of irreversible decline in capability, tolerable physical or psychological suffering, natural death has been reasonably foreseeable. Has to be. Find it. Okay, so the internet chat I saw about people opting for it because of depression was just normal internet hyperboles. Oh, okay. So this is where the concern comes in, because like there's changes in the pipeline starting for next year, specifically March 17th of next year, where it's like, yes, as of right now, at least on paper, okay. Just as like on paper, you're not supposed to receive medical assistance in death as a result of abject poverty. But we just went through a story, like for that person, that was basically what drove them to apply for it. But starting on March 17, 2023, Canada's MAiD law will change, allowing people whose sole underlying medical condition is mental illness to be eligible for an assisted death. So like that criteria that I just outlined, where it says like you have to fit all of these criteria. Go back to it. Yes, this is changing in 2023, where potentially depression or like severe depression may be eligible. Maybe. Where was that story? Oh. Many things open. Close it. Oh no, right here. Okay, so it's relief. The relief is what I seek. John Scully is an 81-year-old retired journalist. After a 35-year struggle with severe depression, anxiety, suicidal ideation, and post-traumatic stress disorder, Scully will soon be able to ask for medical assistance dying for MAiD. On March 17th, 2023, Canada's MAiD law will change, allowing people whose sole underlying medical condition is mental illness to be eligible for an assisted death. So again, it might be it's eligible. Whether it's approved or not, different story. I would probably play some music, and I would die peacefully. Old CTV's W5. I don't want to botch it again. I screwed up twice trying to kill myself. Yeah, so I don't disagree with you. Which is why, as part of some of my tabs, which is why, as part of the safeguards, his request must be in writing after the person is informed of grievous and irremediable condition. Written requests must be witnessed and signed by 2 independent witnesses, and 2 independent practitioners must confirm eligibility. Criteria are met. So, you know, there are hoops to jump through. And as I alluded to earlier, in an ideal world, sort of going back to this study, or as they say, found. Yeah. Right. So, where is it? So, neither palliative care nor psychiatric consultation is mandatory in Canada for patients who request MAiD, which is like, and it seems like, a small minority of people actually receive a psychiatric, you know, consultation, before, or they're either approved or receive MAiD. But you know, in an ideal world, would I want 100% of people to receive a psychiatric assessment or consultation if they apply for MAiD? Yes, I would like that. If there were, you know, unlimited resources, and that there were no issues with accessing a psychiatric assessment. But as they outlined here in this article, it's not mandatory, and like the shortage of psychiatric specialists in some regions could make this requirement a substantial barrier to accessing MAiD, right? So it's like, it's a cost-benefit analysis, right? Where it's like, you know, if you make it mandatory for a psychiatric assessment, like, sure, you might increase the confidence that this person is in their, you know, right state of mind, that you know, they're making an informed decision or more informed decision, but at the same time, you might be disqualifying people just because, like, they don't have access to psychiatric assessment, and so it's just like really tricky, at least in my mind. It's well, what I would say is, like, I'm not for prisoners, or, like, you know, I don't think, just as based off of what we've gone through here, there are some clear flaws with how Canada is administering medical assistance in dying, and I would say, like, totally how Canada is trying to deal with criminals by sending them to prison is totally wrong. And like, yeah, Canada's prison system is a whole other story. And I'm definitely, you're not gonna hear me advocating for Canada's prison or judicial system, at least not in its current state. So he says he is clear-minded and competent. The evidence is in 3 books he's written, including Am I Dead Yet? A Journalist's Perspective on Terrorism. He's already started the paperwork for the procedure and has the blessing of his 2 children and his wife of 57 years, Tony. So if they've been married 57 years, whatever, they were at least 18 when they got married. So this person's like at least, like, whatever, 70, 75 years old. Outspoken MAiD provider Dr. Ellen Wiebe wants to help patients like John Scully. Mental illness and physical illness both can cause unbearable suffering, says Dr. Wiebe, already provided MAiD to over 400 people with physical illnesses. Canada's Supreme Court and federal government are on her and John Scully's side. A rush for the doors. MAiD became a legal medical procedure in 2016. It was first offered to those with terminal illnesses such as cancer. In 2021, the law was amended to include non-terminal physical conditions, such as chronic pain. Mental illness was initially excluded to give the government more time to come up with safeguards, which an expert panel of psychiatrists recommended in May of 2022. Just like for physical illnesses, Canadians with mental disorders will need to show grievous and irremediable illness, suggesting their mental condition was incurable with an advanced state of decline and intolerable suffering. Oh yeah, choice of the, okay. So given this added provision of the choice of the prisoner, right? Like not forced. Well, let's just say I don't think anybody should be having a life sentence in the prison system in Canada anyways. So like that's how I would solve that. But I would say, like, given the way you framed it, and assuming that there's no choice but to have these prisoners, to have these life sentences for these prisoners, and I don't disagree that they should have access MAiD. But I'd be more in favor of like reforming the prison system and like not having life sentences. Let me see. We're all under some form of court or control, and where you draw the line versus dying can be tough. Yeah, totally. Totally fair. So, 2 assessors need to confirm the request, and the patient must be found to be competent to make the decision, with a minimum 90-day assessment period before death is provided. Dr. Weeb says more than 1,700 Canadian doctors and nurse practitioners now have 6 years of practice in assessing suffering patients with physical illnesses. When assessing someone with a mental illness, she feels the questions are the same. Do they understand their disease? Do they understand the prognosis? Do they understand their choices? Under the recommended safeguards, people with mental illnesses will also have to show they have seriously considered other treatments and refuse those treatments if they find they're unacceptable. John Scully would likely qualify. I've tried every single so-called cure, says Scully from his Toronto apartment. He has been hospitalized 7 times, been on multiple medications, undergone counseling, and has 19 treatments with electroconvulsive therapy. So this is basically, this is the technical or fancy medical term for electroshock therapy. That sends shocks to the brain to lift depression, which, like, even though, in movies, the way it's depicted, traditionally, like, pretty barbaric, but, like, the modern evidence, where appropriate, for ECT, it does appear to have, some benefits when administered appropriately in, the proper setting. Yeah, exactly. Complete informed consent, as opposed to, like, at least the way it's sometimes shown in movies, it's like it's forced upon the patient. So he is now on 30 pills a day to try to manage his chronic pain and health problems. He's not alone. CTV's W5 spoke with several Canadians with long-standing mental disorders who welcome the imminent change. There's going to be a rush for the doors, says Mitchell Tremblay. The 40-year-old says he was diagnosed with severe depression as a teen, and he also deals with anxiety, alcoholism, personality disorders, and continual thoughts of suicide. Can't work and lives in poverty on a disability payment of just under $1,200 a month. So, like, yeah, again, just here is where Canada is failing those with a disability. Like, if this is the type of support that a person with a disability receives, like, it's no wonder that they're applying for medical assistance. This is basically an unlivable income, at least in my mind. Yeah, like this is below the poverty line. As I mentioned earlier, in the study that I just showed, like, they defined being poor as someone making less than $40,000 per year in income. $1,200 a month, way less than $40,000 per year. You know what your life is worth to you, and mine is worthless, says But some experts warn Canada is about to offer what they say will amount to state-assisted for the mentally ill at a time when health services are strained. At the regular morning meeting at the Canadian Mental Health Association offices, Barrie, Ontario, a team of social workers and nurses and psychiatrist John Mayer discussed the people they are trying to help. A big part of their work has been suicide prevention. I had a patient who talked to me recently about MAiD who wants to die because of his belief no one will ever love him, Dr. Mayer told W5. He says colleagues have shared similar stories of patients in care inquiring about how to stop therapy and qualify for assisted death. And yet, even though that's, greater than $1,200 a month, like, even that is, like, way below, what you should be given. Because even then, like I said, in the study that I just covered earlier, their cutoff was like, oh, if you're below $40,000 in annual income, you qualify as poor in that study criteria. And like, totally, even 17K is way less than what you should be given. Like that, in my mind, that's like half of what you should receive. And like living on 17K a year, like with today's like prices, like virtually impossible. Dr. Mayer says the wait times for our treatment programs in Ontario are up to 5 years. There are cycles of illness, some of it's up and down, might be years, and then there's a burst of illness and suffering that we then take care of, says Dr. Mayer. I understand the reference. 1 second. So, shock therapy is not banned. Like it's not like in whatever regular use, and we have evidence to show that for certain conditions, and it has a niche use, it does appear to be effective. And like this is now like an evidence-based therapy, but it has to be used in a very specific context. Let me see. And that is a good question. But I can say if you can show that you've sought treatment, you've gone through a number of treatments, and you kind of like exhausted maybe not all your options, but the majority of them. Like, I think you can make a case, or you can build a case that, like, all of the things that you tried has not relieved your suffering, that you could potentially be eligible for MAiD. So MAiD for mental illness is too close to suicide for its comfort. You're assisting someone in the completion of their suicide. The doctor is the sanitized gun, says Dr. Mayer. One of his key concerns is how anyone can determine if someone with a mental illness is incurable, as is required by the legislation. I'm not at all disagreeing that there are people who have an irremediable illness. What I defy you or any other person in the universe to prove to me is that it's this person in front of you. Which, like, yeah, it is a challenge. There are pretty much, like, some impossible questions to answer. And we just gotta go by kind of, like, probabilities, and hopefully, more than hopefully, expert assessment. Serena Bain says all this talk about MAiD for psychiatric disorders has only heightened her thoughts of suicide. The 24-year-old who lives in Surrey, BC has severe depression, anxiety, and borderline personality disorder. That sounds like a very heavy mix. She was hospitalized once when she told the doctor she was planning her suicide. But despite her disabilities, as she calls them, she's completed a university degree and is preparing to start a new internship in Ottawa. Her worry is that if she spirals downward and hits a rough patch, she might be suicidal enough to ask for MAiD and qualify. A lot of the conditions I have, they're perceived as being severe. They've been consistent. I've had them since I was a teenager, yes. Serena's been on a waitlist to see psychiatrists multiple times. This year, it took like a year and 3 months, she tells W5. Studies confirm that there are long waits for mental health care across Canada. 1 in 10 Canadians looking for counseling services wait more than 4 months. even longer for children and youth. Rena says the mental health system is broken. It's not consistent, and honestly, once they move you to another service, there's usually a wait list for that. And like, yeah, just as like, you know, I'm not of the position that, you know, MAiD should be used to solve poverty. I don't think, not my position, that MAiD should be used to solve, you know, the mental health care crisis in Canada. Where it's like, yeah, you know, mental health resources are underfunded. And like, yeah, I don't want people seeking MAiD because there's failures in the mental health system. So I definitely would love to talk to you about it, but also at the same time, I would want to give enough time to the conversation. So I don't want to put that on hold, so we could have maybe a more full conversation. If you're available tomorrow, because I plan to stream again tomorrow, because right now, I'm looking to wrap up soon. I need to go to bed and go to the gym tomorrow morning. But yeah, or if you're available, like, pretty much, just let me know when you're available, and I can probably accommodate. Or I'm sure we can line up our schedules. So, she wonders why governments don't offer more mental health services or making MAiD widely available. And like, yeah, probably one of the, just as we kind of alluded to earlier, there's a shortage of psychiatrists, or like in certain regions. You know, they don't have great access to mental health resources. It's like really tough. More accessible healthcare, more psychiatrists should be available, more forms of therapy should be available. Not only are there long waits, people with mental disorders often face problems with access to healthcare, housing, and food. According to the Canadian Mental Health Association, 70 to 90% of people living with serious mental illnesses in Canada are unemployed. Yes, I will watch the video before the stream. Before I end the stream. I'll probably use it as my outro video to wrap up the stream. Just going to get through this, and then we'll get to the video. So, although MAiD accessor Dr. Ellen Wiebe says there are weaknesses in the mental health system and wait times are too long, it doesn't mean patients shouldn't necessarily be eligible for assisted death. Would I like there to be better mental health treatments in this country? Yes, of course. But if delays in care cause irremediable pain, it is still suffering. Canadians are also questioning whether offering a mentally ill person assisted dying while they're awaiting treatment is the right thing to do. The CTV News Nanos poll suggests that 61%, almost 2/3 of Canadians, are unsure or don't support MAiD for those waiting. I don't know how to feel about that. I'm pretty on the fence. We can make it more into yeah, totally. Want to have an in-depth conversation? I'm all for that, for sure. If anything, I definitely prefer an in-depth conversation, like superficial. So the most liberal in the world. As it stands right now, bioethicist and Washington-based psychiatrist Dr. Scott Kim says Canada is about to become the most liberal country in the world in allowing those with mental disorders to access assisted death. Dr. Kim has been studying psychiatric euthanasia and its use in countries such as Belgium and the Netherlands, where it's been practiced for 2 decades. Both countries have more stringent requirements for proving an illness is I don't know why I have trouble with this word. Irremediable, says Dr. Kim, by requiring psychiatric input and putting more emphasis on trying additional therapies than is recommended in Canada. Belgium also has a 2-track system in which patients and doctors look for potential therapy and treatment, while another team assesses the patient for aid. The rates of approval for psychiatric illnesses in Belgium and the Netherlands are low, says Dr. Kim, ranging from just 1 to 3%. A large majority are rejected, he says. Overwhelmingly, the main reason is there are other alternatives. In Canada, there's some disagreement about whether patients who want assisted dying need to try treatments, or only that they must be informed of what is available. Dr. Ellen Wiebe says healthcare professionals who provide MAiD are careful to review the treatments and the patient has undergone, though more treatments can't be forced on anyone. Right. And this is, I think, something that gets overlooked when it comes to talking about MAiD and like exhausting all options. Like as part of at least healthcare in Canada, you have to, well, generally speaking, unless you're deemed as incompetent, but you have to respect patient autonomy, and the patient has a right to refuse treatment. And so when someone says like, oh, you need to show that you've exhausted all your options, well, no, not necessarily. Just because like a patient has a right to refuse, as in a doctor can offer a treatment and you can refuse it. And that treatment may very well be effective. Like whatever pill or that they offer, it may very well be effective, but you have the right to refuse that treatment. And therefore, you may potentially be eligible for MAiD. As long as, as long as it's recognized or you're aware that, you've exhausted all your options by rejecting all of the viable options to you. Individually, assessors will look at what treatments they have received and say you haven't tried this, or this, or this, and then the patient would have to convince me that there was a good reason not to try them. Canada under the microscope. Canada has already been under the international microscope for its increasing use of medically assisted death for physical disorders. The latest Health Canada report shows a steady increase over the past 6 years to where 3.3% of all deaths in 2021 were from MAiD. That has quickly approached the European average, where about 4% of all deaths are assisted deaths. Which, like, so far, this does not send alarm bells off in my brain, although maybe I'm desensitized to these. And it's good that we're tracking this, where, yes, we've seen an increase over the years, but like, this is fairly new, right? In the past 6 years, where like I'm reasonably sure and confident that this will probably plateau off, right? But it's good that we're tracking, and if we see some sort of like exponential growth in medical assistance in dying, pay attention to that. Hopefully we can course correct. I've had colleagues call me from other countries saying, what's going on in Canada, says MAiD skeptic Dr. John Mayer. But Dr. Weeb argues the new rule acknowledges the plight of those suffering from intolerable mental illnesses. If you are suffering unbearably, you've got the right to say, I've had enough, and you'll go through a process with safeguards, Dr. Weeb. John Scully agrees. MAiD promises him relief from almost 4 decades of mental suffering, but its arrival also makes him sad. It just formalizes the utter failure of psychiatric medicine. A joint parliamentary committee has been reviewing the issue and is expected to make its final recommendations on how MAiD will work for mentally ill Canadians on October 17, 2020. Right, and on this topic of the failure of psychiatric medicine, let me see if I can bring it up. I'm going to cover this study, even though it's a difficult study, on a future stream. Moment. One moment. So yeah, as the person towards the end quoted as saying, it just formalizes the utter failure of psychiatric medicine. And this was published somewhat recently. Functional neuroimaging in psychiatry and the case for failing better. Where like this is a long study and pretty complicated stuff, but basically what it boils down to is like when we diagnosed psychiatric illnesses, like we are not relying on biology. We're not relying on neuroimaging, right? There's nothing that shows up on, at least as far as I know, And as far as like this article is concerned, like nothing shows up on like a brain scan that allows you to diagnose any sort of psychiatric condition. And like that's a problem, right? Like we are solely relying on like symptom reporting and whatever ICD or DSM criteria. Where it's like there's like that, there's the disconnect, what we're observing and the biology, where it's like we don't have really good biological grounding of psychiatric illnesses. That's why like there's this case of we're failing better, where it's like we really don't understand these psychiatric conditions really at all at a biological level. And even our treatments, even though like SSRIs, like they alter brain chemistry, and yet like the evidence of their effectiveness, or like the evidence around the hypothesis that SSRIs have been manufactured is like questionable, or is like called into question, where it's like it really seems like we're like shooting darts at a dartboard in the dark, and just like throwing stuff at the wall and hoping something sticks. Let me see. Catch up with chat. As I viewed, we need to separate different versions of MAiD. Someone is suffering from an incurable chronic condition, which will kill them. That could be type A. And that's where it gets tricky, right? Because like, certainly some psychiatric conditions maybe don't necessarily directly cause death, but let's say they increase mortality, right? And so how do you factor that in when it comes to like the decision for MAiD? However, to put all of MAiD as one law is incredibly foolish. I don't necessarily agree. If someone blocks off one stream, water may take, and then it takes the other, gravity not still in effect. No, just as patients will take the easiest route subjectively, solve their issues, so will the institute. Yeah. Oh yeah, path of least resistance. Totally. I understand the sentiment that you're conveying. MAiD cannot remain unchallenged and public debate must continue. Absolutely. This is one of the reasons why like I'm having this stream. Like I'm trying to at least paint a more complete picture. Yes, I'm clear in my position. I support it. And like I covered some of the studies and the data, although I still have more studies that I want to cover. I covered this one, and even just like I would say this is a good review, scoping review of like how does MAiD like work in reality, where a lot of people think or are under the impression that MAiD is just you apply for it, you get approved, and the doctor administers like the lethal drug. Well, that isn't true in 100% of cases, and as alluded to in one of the articles, obviously in some countries, if I remember correctly, like it's only the patient that can administer whatever lethal dose of whatever pharmaceutical, and it's not always doctors. It's in the vast majority of times, it's a doctor administering or providing the medical assistance in death. But there's some percentage that's carried out by nurses. And it's alluded to here towards the end of like, yeah, most commonly the role of physicians was prescribing and administering medications. And then there's also nurses' roles included administering medications, but it's a minority, and supporting the patient. There's a lot of nuance to it. And what people think it is very often disconnected from the reality. Let's see. Safeguards are never capable of countering faults. Totally agree there. The failure of psychiatry in Canada is something I can definitely... yeah, I have no doubt that you can speak to it better than I can, although I'm definitely aware of many of the failures, not only of psychiatry in Canada, but of psychiatry writ large. One thing I think many critiques of MAiD do not take into account is that many of those who do not have access to MAiD end up attempting suicide in instant, more destructive manner, which can lead to harm and our survival with permanent absolutely, 100%. So yeah, that wraps up the MAiD portion of my stream. Let me close some tabs. So, we're gonna end the stream on this video. Thank you to Oily Olive for sending it. It is an Abba and Preach video. Even though, as far as I can tell, I don't generally agree with, from anything that I've seen, which is not a lot of their content. I don't really agree with anything they say, but I will always try to maintain an open mind. Give it a watch.
That people who order Uber Eats or DoorDash understood what it's like to be a driver. Like, I just spent 45 minutes on a delivery and had to pay $3 to bring this person their food because there was no parking, no free parking anywhere near their building, and they refused to come out and meet me. They tipped me $1.50 and Uber paid me $2.50. Like, I got approved 3 times the rent for income in 2 weeks, and I can't. And it doesn't matter that I'm working multiple jobs. It doesn't matter that I barely sleep and can barely afford to feed myself. I'm about to be homeless for the 3rd time since May. And it's all because people don't tip their delivery drivers. Like, how hard is it to throw us $5?
He said something I thought was interesting. He said, the reason I'm about to be homeless is because people don't tip their delivery drivers. Now, the reason why you're about to be homeless, well, let me rephrase. One of the reasons why you're likely about to be homeless is because a lot of companies get away with not paying their employees living wages, whether it be restaurants or whether it be delivery services. The idea that it's on each individual consumer to pay your living wage when your employer should is wild to me. Is it maybe not necessarily the best thing that they didn't tip you that much? I guess. But have you never asked yourself why Uber gets away with taking such a large cut, not only from the restaurant, but from you, the driver, as well? It's easier for you to get mad at an individual because that's a face you can put on it, rather than a large company, which is faceless and locationless in a lot of times. So, to me, it seems like you're putting your frustration towards the wrong places, rather than it being towards the right places, which is.
Yeah. So far, I don't disagree. And like, yeah, it's, if I remember correctly, like, you know, one of the reasons why, you know, Uber Eats gets away with this, is because like they are technically not employees. I think they're like contract workers or like whatever, they're gig workers. And so like it allows more room for exploitation, my understanding.
These huge companies who get away with fleecing a lot of their employees, contractors is what they prefer, actually enough to pay them benefits. But those are my thoughts on that.
I worked in the industry, the food and beverage industry, and it's an industry where you, most of the times, wherever you are, you have to tip the people. That's what is expected as a patron, for you to tip the people, right?
And like, you know, at least again, as far as I understand, tipping seems to be kind of like a mostly like North American thing, like, and I'm mostly in favor of just like abolishing tipping, and just like paying people who rely on tips like just way more.
Now, on average, it's 10 to 15% of your bill to tip the person, and I understand that that's how it works. That's how it's been working. It's been like that for ages. You're a bartender, you tip your bartender. You go to a restaurant, you tip your server and stuff like that. I had jobs where I had to be tipped. It was fun because, you know, where I was working, I was good at what I was doing, so I was making tip and stuff like that. Now, I don't know about every places in the world that require tips, okay? But where I'm from, where I've been working with the tips, there's one thing that's a lot of the workers omit. The tip is at the customer's discretion. Always. They push this thing where whenever you have a service, it's 10%. That's the basic. If you have good service, it's 12 to 15. If you have great 50 service, it's 18 and up. But it is at the discretion of the people. And sometimes it's really expected. It's expected. They want you to tip. They want you have to tip when it's at the customer's discretion. And I've had people ask for a tip even though the service was poor. But that's besides the point. One thing I would say about that is that it's not because it's been like that for ages that it's right. Then it has to stay like that. I tip whenever I go out. I'm a good tipper. I tip when I go out. But if we go for that basis of tipping, that's what I think. If we go for that basis of tipping, it's not just the server that should get a tip. Yeah, you split through all the servers, but the person at the kitchen should get a tip. Everybody should get a tip, right? It's not often the place. Instead of requiring for a tip, and I know that there's some restaurants that have been doing that, instead of accepting a tip, increase the bill and know that there's a portion that's going to just increase the wage of all your workers. That's what I think. And that's from someone that worked in the industry. You know what I mean? When you said it's because of people like that I'm going to be homeless, I disagree, just because, yes, you took a job that has tips in them, but because of that, you know that you're going to have some good days and you're going to have some bad days. You cannot necessarily rely on your tip for your whole livelihood. It's not possible. You cannot just lean on me and just decide that your tip is going to take care of everything. It's not logical. You're putting yourself in when you're doing that. If you have a good tipping job, yes, you do. But now you're relying on people that don't know and don't care how much Uber is charging you. They think you paid, so they don't care. There's no information about that. So saying I had a problem, and you could rewind the video when he said that, I don't know what I made, but I made a face. It's because I'm like, no, you can't solely rely on them and say I'm gonna be homeless because of them. It's part of it, but it's really because of your choices. Maybe I'm harsh. Maybe I'm very harsh. But it's coming from someone that worked in that industry.
I mean, it's so many things, rent.
Oh yeah, what is choice? And as Desolate Mirror alluded to earlier, the vast majority, if not everyone's under some form of court. Yeah, I definitely had a strong reaction to that.
Prices are increasing like crazy.
Yes.
In the state specifically, the minimum wage is trash, or for a lot of people unskilled.
Yes.
It's hard to have labor and have a decent rest, and then they won't pass this $15 minimum wage, which is a whole different story. Like, there's a plethora of things that are leading towards the fact that you are impoverished. But to put it on other individuals who are not paying your bill, it's like, do we pay tips for mail delivery? No. Why? Because when you're buying and you're paying for the service, the delivery driver is being paid a living wage. He's being well compensated. So there's no need for that kind of transaction. You are doing the exact same job. There is zero difference. You are taking something and delivering it to another location. The only difference is your employer will not pay you properly. That is not my problem, nor is it my fault. Hike up all the prices, but they don't want to do that because they want to make as much money, and they'll take advantage of you. But that's not my fault. So if you think I'm going to subsidize your salary, or if you think you can live that way, I'm sorry, you got another thing coming.
The tip thing...
The tip thing is a problem. It's not good.
Yeah, the tip thing shouldn't be... I don't mind the tip thing, right? The way I'm thinking, the tip is really an added thing. It's a plus on top of... The base price should be... You should be good with your base price. And then the tip is extra. Now, what they do is that the government even... charge you on the tip. So when you don't tip, that's in this province, when someone doesn't tip, for example, a server, the server is basically paying for your drink. It's being taxed for your drink, because the way the government works is that they assume that all the money that you made, there's 10% at least that you took on tip. And there's good days, there's bad days, right? And maybe we need to...
Yeah, I can say in Quebec, they pretty much operate we have a minimum wage in Quebec. I think around $12, $13, obviously Canadian. But there's that exception for service workers, where it's they get paid below minimum wage because it's assumed that they'll make tips. Thus that'll boost them up. I don't see why there's that exception there. That's a ridiculous exception. And regardless, the minimum wage in Quebec should be higher anyways.
To change that, because the tip It's really just supposed to be an added thing. If your base price is trash, think twice about that job.
And there's such a bullshit. Like, what, you only give good service if you get tipped well? That's nonsense. Go to any other country where people prepare food and they do all this stuff. Even if you don't tip, they're paid a wage, so they still serve well. This idea, what, you think every other job that doesn't have tips involved, that just has a wage, they don't have good customer service? You're not a special industry. It's not special.
No.
You should be paid a wage that is appropriate like everyone else. And I think this whole system is stupid. Coming from somebody who tips, I have no problem. I do it because this is where I live. It's the environment, whatever. You abide by the customs of the area. It doesn't change the fact that the system is retarded. It is. It is. There's no way around it. But to think that individuals are the reason why you're not paying, no, it's because they don't want to pay you a wage. That's what it comes down to. Even if the food price goes up. I mean, it's already up for us. Even if we didn't tip you, if we tipping you, it's probably going to be the same price than if you just added the tip into the price of the food. That's what it comes down to.
The delivery thing is luxury. Like the Uber Eats, the DoorDash, that's luxury.
Yeah.
That's luxury because what?
But they charge more.
But that's what I'm saying. It's luxury.
Right. But
because if you take your ass to the McDonald's, it's not gonna.
Here's the thing: Uber's eating. You know why I say that? Because one, they take a cut from the restaurant, and they take also a cut from the driver.
Yes.
Right. So they're getting their cut. The problem is in that the driver's completely ignored. So do I think it's fair? No. Do I think it's right? No. But it is what it is.
But you have to take it to the right person.
You know. So listen. I understand maybe why he would have said those things, because like when you're facing homelessness.
Yep.
It's emotions running high. You're afraid. You got a whole bunch of things going on. So I don't wish that on you, nor do I think it's good. And I recognize things are tough, but I think placing your blame in the wrong places doesn't help either. So I think there's a way to have sympathy for what you're dealing with, and also disagree with that sentiment. We need to change the system, because even if we choose to tip you today and tip you tomorrow and all that stuff, like, doesn't mean that you're going to be good next month when rent prices, or next year when rent prices go higher. What am I going to have to tip you $6? How about $7, $8, $9, $10? When does it ever end? We have other societal issues that we have to fix before we can get to stuff, you know. So
the slippery slope of tipping.
That's my thoughts on that. It's just unfortunate, and so I'm sorry for your situation. I hope it improves. That's all I got. Yeah.
I mean, not the absolute worst takes. You know, there was I agreed with them in the beginning. Second. All right. But still, whatever. I've heard of worse takes. And if this is, you know, yes, this is as bad as it gets for ABBA and Preach, yes, they're not the worst. Well, I never thought they're the worst thing in the world. I've heard some pretty awful things of the limited stuff that I've watched of ABBA and Preach. So we're gonna look to rate out someone to rate out to. I think we're gonna rate out Prime. They're streaming. But yeah, I want to thank everyone that passed by. So I plan to stream again tomorrow, and it's looking like I'm gonna have a conversation with Zeron about further medical assistance dying. But if not, you know, if they're busy or if they change their mind, I definitely have. There's a lot more studies and stuff that I want to cover. Like I said, wanted to cover this, and I had a whole bunch of other stuff on the back burner that we covered. But even if I don't get to cover it tomorrow, I'll cover it on the next stream. I have a whole bunch of content piling up. But yeah, I want to thank everyone for passing by. Desolate Mirror, Okkel, Oily Olive, Zeron, Cernu, I'm Bob Marley, of course, can't forget Bob Marley. Zero, and I'm missing a bunch of people. Like I said, I plan to stream again tomorrow at roughly the same time, about 8:30 p.m. Eastern time. We're gonna raid into Prime. Definitely give them a follow if you're not already following them, just because like they're kind enough to invite me on their panels. And as frustrating sometimes as the panels can get, I'm still grateful and appreciative. Prime continues to invite me on. Oh, and speaking speaking of Prime, thank you, Paul, for passing by. Yeah, thank you, everyone. It's been great. First time watching it, I disagree, but after watching, which is, so at the very least, it's good that, you know, you maintain an open mind, and that, you know, your mind can be changed, because definitely not true of everybody. So yeah, we're gonna raid into Prime. Until next time, everyone, take care and be well, and thank you again. Gotta wait for the raid. You win. Oh yeah, and like, the camera, got the new camera. Sorry that I didn't get the workout stream running earlier today, but I think I solved the issue, and the next workout stream could be with the new camera, with better video quality. Yeah, take care, everyone.
Anything and just work on abolishing the police. So how close are we to abolishing the police?
How close are we?
Yes.
I don't fucking know. Are you what? I'll tell you what I